Okay, everybody. I think we're going to get going. So it's just after 8, and we're going to try to stay on time. So good morning. On behalf of the New York Society for Surgery of the Hand, I would like to welcome you all to the 2022 Hand Surgery Review course. We have approximately 450 registrants for this course from throughout the United States and internationally. I myself, as well as Dr. Renata Weber, are the course directors for this course. And this is our course faculty. I would like to thank all of our esteemed course faculty for their time and commitment to make this course possible. All the faculty are members of the New York Society for Surgery of the Hand and represent the top health systems throughout the metropolitan area. These are the lectures that both the live and pre-recorded lectures, and the pre-recorded lectures are available at the NYSSH.org website, which I'll show you afterwards how to access. So I want to give everybody, for our registrants, a little background on the New York Society for Surgery of the Hand. The New York Society for Surgery of the Hand was organized in the early 1960s when a small group of surgeons met for dinner to develop professional contact among like-minded individuals in an informal social setting. This was in addition to the ASSH, the American Society for Surgery of the Hand. As such, it was the first regional hand surgery society of its kind and was a prototype for other similar groups throughout the country. It has grown to represent a present size of 120 members, and it is the largest regional hand society in the United States. It still embodies the purpose of the founding members in promoting camaraderie and exchange of knowledge amongst hand surgeons. Article 2 of the Society's Constitution states that its mission is, quote, to promote and foster the highest standards of surgery of the hand, to promote education, training, and research related to surgery of the hand. And that is why we host this course every 2 years. This course is a biannual course that the NYSSH runs to educate residents, fellows, physicians, physician assistants, OTs, CHTs, and other medical professionals who are involved in the care of the hand and upper extremity. Up until 2 years ago, this course was held at Columbia University. We usually had approximately 75 to 100 registrants. And to defray the cost of running the course in person, we had to charge registrants. 2 years ago, because of COVID restrictions, Dr. Dan Polich, who was then the NYSSH president, made this a free Zoom webinar. The course was a resounding success with approximately 700 registrants from throughout the world. We received excellent feedback for the course. Because of the success of this course and the wide reach that we're able to achieve by doing this online, it was decided to continue this course as a free live webinar. I would like to thank my friend and colleague, Dr. Dan Polich, for all the legwork that he did 2 years ago. Today's course is a testament to his foresight and hard work. This is the schedule of today's lectures. We will try to stay on time. After the first session, we'll have a Q&A session, a break for 20 minutes if we stay on time, and the second session will be led by Dr. Renata Weber, my co-host. As I said before, there are 10 pre-recorded lectures. These are the pre-recorded lectures, and you can access these online. Essentially, what you need to do is you need to go to the NYSSH website, nyssh.org, and then you find these lectures and you click on the play button to the right, and then the lecture will come up and you play it. Please note that because the lectures are uploaded onto the YouTube channel, you may be directed to sign into YouTube because some of these lectures are age restricted because of the medical content. So all you need to do is sign into YouTube, either using your Gmail or YouTube account, and you'll be able to access all the lectures. I think 2 or 3 of these are restricted. Finally, I would like to thank our sponsors, East River Imaging, Dr. Larry Hurst, Hand Surgery Resource online website, MedArtist, Skeletal Dynamics, and Stryker. Each of these companies have donated funds to help the NYSSH defray the costs of running this course and has allowed us to keep it free to all registrants. Okay, that's it for my introduction. It's time to start. Our first lecture will be given by Dr. Kate Nellens, who is now the secretary of the NYSSH. and she's one of my colleagues and friends as well, as she works at Northville, and she'll be lecturing on fractures of the hand. So Kate, I am going to stop sharing and turn it over to you. And I'm going to ask everybody to mute themselves until you're lecturing. Thank you.
All right. So welcome, everyone. Happy Saturday morning. We get to start with some finger and metacarpal trauma. So for this, I really tried to think about the high yield topics for the OITE, things commonly missed in the ER, and some basic treatment. Again, we're not going into any depth in any single kind of problem, mostly an overview of these traumatic injuries to the fingers and the metacarpals. So here we go. So kind of starting distal and going proximal. Mallet fingers, really common. Again, a soft tissue mallet is where the extensor tendon pulls off the insertion on the distal phalanx. Splinting is by far the kind of majority of our treatment. Again, 8 to 12 weeks of splinting. A question I saw recently was complications in splinting are about 50%. These are mostly skin problems. Bony mallets, kind of come in two different types. Obviously, the more joint involvement there is, the greater chance that you have the subluxation, but it's not necessarily a given. So on the left there, you see a bony mallet with about 50% of the joint involved, but there's no subluxation. Those would do very, very well with splinting. But on the right, you see that volar subluxation of the distal phalanx, the gapping at the articular surface, and that's when operative indications are appropriate. No one operative indication or operative technique is probably better than the other. And again, those have about 50% complications with, prominent pins, pin site infections, or problems with the anchors. So again, minor 50% complications with splinting, kind of more major 50% complications with surgery. Those are kind of just some numbers to remember. And why do we treat this? It's really the risk of developing a swan neck. Not everyone will, and Dr. Posner was going to go into this, I'm sure, quite a bit more. But the idea is that we're trying to avoid this positioning. All right, so moving on to kind of an adolescent type of injury, Seymour fractures. They like to put this on there because this is a kind of a do not miss type of injury in the ER. And so what you're really looking for in a picture or kind of clinically is that that nail is elongated and kind of outlined here. The nail is kind of just longer. And what's happening is that the germinal matrix becomes interposed at the physis. And so if this goes unreduced, one, you're going to have a nail deformity, and two, it's an open type of injury, and you can end up with an osteomyelitis. These are easy to miss, but the treatment is really reduction, pinning if necessary, but the key is just identification. So kind of moving on to other injuries that happen at the fingertips, jersey fingers. I would tell you that this is the one classification in orthopedics, it seems, where type 1 is the worst. So these type 1 injuries are where the tendon retracts all the way back into the palm. These need to be addressed urgently, really within 7 to 10 days. And if they get missed, lots of times it's just an FTP excision, and then they end up with, the ability to make a fist all the way over on the right side because they can't have pull through the DIP. A type 2 is somewhere retracted within the finger. An MRI can be helpful, or an ultrasound. Type 3s are where you have a bony avulsion, and those actually do very, very well. Even surgery a little bit further out have good outcomes. But mostly it's just remembering that this classification system, 1 is the most severe and is really urgent in terms of operative indications. What you don't want to do operatively is kind of open this all up. They're going to get very stiff and scarred. The idea is that we're kind of threading the FDP tendon through with minimal incisions. So don't do that. All right, so moving on to dislocations. So I would tell you 90% of PIP dislocations are simple. They go dorsal. It's a hyperextension type injury. They need a reduction. You need to avoid hyperextension kind of going forward, and then you start early motion. A volar PIP dislocation is much different. It's a bad actor, and what it's doing, if you kind of look at that X-ray, is it's going to disrupt your central slip. And so an unrecognized volar dislocation goes on to a boutonniere, and that's pretty serious. So, splinting that in extension for 4 weeks is very different from your dorsal dislocations. And so just kind of, it's not, you need to know whether it's dorsal or volar if a patient's coming in from the ER and so they had a PIP dislocation, because it really does change treatment and outcomes. So moving on to these fracture dislocations, I would tell you that when these walk into my office, I'm never happy. I don't think any of us are. These are hard injuries. However, we kind of think about it as stability based on a degree of articular involvement. So anything kind of at the 25% or less is pretty stable. We try and get those moving. Unstable fractures need surgery urgently. So the most common we see are these little volar plate avulsion fractures. I try and tell parents we treat these as more of like a PIP sprain. We get them moving. We avoid the hyperextension type of mechanism by buddy strapping, but that's really about it. These are not major. But injuries like this, if you catch it at 3 days, we've got options, and I'll thank Dr. Strouch for this technique. Really restoring the articular surface, reducing the subluxation that you see here over on the right-hand side are kind of all things that we're kind of focusing on. So other options, you can do this external frame wiring that creates kind of both longitudinal traction and volar translation to kind of reduce the articular surface, create some movement, and try and get that PIP joint reduced and concentric. However, these never seem to make it into my office within a couple of days. And so these 3-week out PIP dislocations are, I think, especially frustrating. So what we're looking for and kind of our eye is seeing in these x-rays is there's dorsal subluxation, but there's articular impaction and really poor volar bone stock. And so these are the injuries that need kind of some special work. I would tell you historically, volar plate arthroplasty is written about. I would tell you for the OITE, that's never going to be the right answer. It's going to be a distractor. It sounds fancy, but that's really all it is just taking the volar plate and tucking it into the fracture. It doesn't work particularly well. So, I think the correct answer for kind of these chronic ones now is going to be this hemi-hamate autograft. So taking the portion of the hamate at the interval between the 4th and 5th CMC, and then kind of inserting it into that bony defect. It works well. It's a little technically demanding, but it's definitely the right way to go. Here's a couple of pictures. Kind of using the anatomy that's already in the hand. I think this is one of my favorite parts about hand surgery, and kind of creating a new joint there. There's some just kind of follow up. So it does match quite well. So I guess moving on to some more standard finger fractures. As you know, the OITE really likes to think about the anatomy and the deforming forces. I think there are a lot of questions about that. We'll have some going, just in a little bit. But these proximal phalanx fractures, they go apex volar, and so do the middle phalanx fractures, but for different reasons. So for the proximal phalanx, you're really thinking about the central slip and the lateral bands being your deforming force, whereas the middle phalanx, which is that picture down on the bottom, the apex volar deformity is really due to the pull of the FDS, which is kind of the more proximal angle, that arrow there, as well as the terminal extensor tendon kind of pulling into extension there. All right, coming back to the thumb now. So these ulnar collateral ligament injuries, really common sports injury and in the acute setting. If it's opening less than about 30 degrees, it's probably not a complete injury. You certainly can get an MRI, but these are reasonable to splint and let heal. If it's opening more than 30 degrees or 15 degrees greater than the contralateral side, that's when you're going to get concerned about a full injury. And what happens is that the collateral ligament is displaced by the adductor and then can't lay back down next to the bone. And so kind of something that looks like this is going to be your clue that the collateral ligament there is now outside of the adductor and can't lay back down and can't heal. You can get a little avulsion fracture. And I would tell you that as a resident, I always had a hard time kind of looking at what a sesamoid was and what a tiny little avulsion fracture is, but you can look for a bite out of the proximal phalanx there. But then also this is going to have a sharp edge where a sesamoid is going to be nice and smooth and around. So they can often be a little bit the same size, but kind of looking for those sharp edges, and a bite out of the proximal phalanx is going to be your clue, kind of as, for the test if you're looking at an x-ray and trying to figure out what the injury is. Okay, so moving on to dislocation. So this is a common adolescent injury, and really kind of thinking about what's interposed there. And for these, it's usually going to be your sesamoid entrapment. And again, this is kind of pattern recognition that the MCP of the thumb is hyperextended, and the sesamoid is kind of sitting right in line with the metacarpal. Kind of moving on to index finger dislocations. I think these are frustrating for us as surgeons, because oftentimes if treated correctly, it doesn't require going to the operating room, but inevitably somebody is on the field, these are usually sports injuries, or is going to try and pull on it, or the patient themselves is going to pull on it. But what's happening is that we got interposition and then kind of a locking down. So this is a common question I've seen come up a couple of times. So I wanted to put it in here and kind of talk it through. So, this index finger here, the MCP is dislocated. You can kind of see the finger floating off without anything underneath it. And what's happening is that in this hyperextension injury, the volar plate becomes interposed at the MCP joint, but those natatory ligaments really kind of create this noose around the metacarpal neck. And then the superficial transverse ligament is kind of the underneath portion of it. So it's really, I think, kind of knowing your anatomy here, kind of memorizing these kind of specific anatomy questions, because they do come up over and over. All right, so metacarpal fractures, I think this is probably the most common fracture we see as a hand surgeon. It's always going to be some teenage boy punches a wall. But these metacarpal fractures, I think the thinking on these has changed significantly over the past 10 to 15 years. So in general, all options are reasonable. 30 to 70 degrees of angulation, non-op, any sort of fixation you want. But we know biomechanically it's not particularly different, but at the same time, it's well tolerated. However, and I think this is going to start making it into the kind of testing material. But in December 2020, there's kind of a randomized trial looking at buddy strapping versus cast for these fifth metacarpal fractures. And I think kind of the bite out of it is really that if you treat with buddy strapping, patients are back to work almost a month earlier. And that's like a very, I think, easy testable question, but it also kind of changes my management completely. These rarely get casts anymore. We get them moving. We do know that greater than 70 degrees of angulation does biomechanically impair them, and they do have kind of prominence dorsally and difficulty with grip. Lots of different ways to treat it, but I think these intermedullary screws are becoming more and more common. I'm a big fan, and I think at this point they do have some of the lowest incidence of complications because of the limited incision going in, and we've all gotten better at placing them. So I think this is my preferred treatment for those really highly angulated neck fractures. So moving on to kind of down the metacarpals here, we get concerned about these CMC dislocations because they are commonly missed. And if you're looking at the AP here, it doesn't look terrible. But if you're seeing this in the ER, the hand is big, it is swollen, something's wrong, but it's hard to kind of tell. And so I think one thing that is nice and to think about is looking at the lateral. And yes, everything's overlapped, but if you kind of start allowing your eye to see this intermetacarpal angle, so the IMA, it's going to be off. It's going to be off by about 20 degrees. So even if things are overlapped, if you're kind of starting to see that they're not all perfectly lined up, that's going to be your indication that there's probably something going on at the ulnar CMC joints. CT scan is never a wrong answer on this one if you're concerned, but the treatment is going to be an open reduction internal fixation. The deforming force on this is really the ECU. It's pulling at the base of the fourth and fifth metacarpals, continuing to kind of proximally pull on this and keep it dislocated. And these are, even if you reduce them in the ER, they kind of can come back out. So that's why open reduction internal fixation is usually our are kind of going to be our answer for the test, at least. Okay, so I feel like these are metacarpal base fractures and CMC fractures of the thumb are really commonly tested, mostly because it's good anatomy in terms of the deforming forces. So I think, this is an extra-articular fracture. I think we need to recognize that. These are extremely well tolerated, but not if it's greater than 30 degrees. So that's kind of our threshold. There's not, lots of different options, but really our deforming forces in terms of why the fracture ends up where it is that, it ends up being apex dorsal because of the pull of the APL there. And then the APB is pulling the distal fragment, as well as the adductor, and then thumb tends to supinate. So you're going to reverse all these for the reduction, and then usually K-wires will do it. So Bennett fractures are going to be the the similar type of mechanism, but it's intra-articular fracture. And so you have to remember that the majority of the metacarpal separates off from the trapezium. It leaves this small articular fragment behind, so it's attached to the volar beak ligament. And that's the constant fragment. So your displacing forces for this one are your APL, EPL, EPB, and adductor. So here's kind of a, what they usually ask for is either the deforming forces or, what's the reduction maneuver. So it's going to be your axial traction, your palmar abduction, again, trying to kind of counteract these deforming forces, pronation of the thumb, and then pressure kind of over top to reduce it. So this is that beak ligament that we talk about right there. Okay, and kind of thinking about treatment, K-wires are usually kind of the easiest, most straightforward way to do this, especially if you're catching it early. I think mostly important is that you're not necessarily trying to capture this small constant fragment. You're reducing the metacarpal to that fragment to get a concentric articular reduction. Okay, and that was a whirlwind through hand fractures. I'm going to finish up a little bit earlier. We can have plenty of questions at the end. So our next.
Thank you. Yeah. Hi, my name is Omri Ilon. Can you guys see my screen?
All good. Yes.
Sweet.
We see
Okay,
you.
let me pull this up. Great. There we go. Yeah, so I'm representing Manhattan Orthopedics, and then I'm also the associate fellowship director at NYU, and it's a great pleasure and an honor for me to be here giving this lecture with the NYSSH. And so let's get right into it. I sadly have no disclosures to report. So I'm going to be talking about scaphoid fractures, and basically,
we see you, but we don't see your sharing of the screen.
Oh, I'm sorry.
So if you go to the bottom, there's share screen. There you go.
Oh, sorry, I hit the wrong. 1 second. How's that? Good?
Yeah, you just have to open up slideshow now and we should be good. We can see your screen.
Because I'm sharing. Yeah.
Just start your slideshow by going to this lower box here. Yeah.
Can you see that now?
Yep.
All right.
Okay.
All right, let's get started. So I'm going to be talking about scaphoid fractures, no disclosures.
Omri, we can't hear you. I think you muted yourself.
Oh my gosh.
There, good.
How's that better? Is that better?
Perfect.
Okay. So it comes from the Greek, which I don't think Andy Samberg was thinking about when he first made this song. Here we go. All right. So my goal today is to hopefully confuse you, because this topic unfortunately does not have a huge amount of consensus. However, I would like to give you the tools needed to think about these injuries and treat them effectively. So hopefully we can at least answer why we treat these and how best to treat scaphoid fractures. So let's get started here. It will end up as being more of a philosophical debate when we get done. So some of the barriers to treating these injuries and evaluating them, unfortunately, is there's no consensus from start to finish. So even proper diagnosis, which imaging modality, how to define displacement, how to define union of a scaphoid fracture, even the type of non-operative treatment or surgical indications. So, pretty much we might as well just throw our hands in the air, but let's try to move forward. So why do we even treat scaphoid fractures? And I think that sometimes we get caught up in, cool surgical techniques and how best to fix these injuries. However, what we're really trying to do is to prevent collapse of the carpus, because as we'll talk about, the scaphoid is the link between the proximal and distal rows. And when that link becomes disrupted, we can tend down a predefined set of collapse called scaphoid non-union advanced collapse, or SNAC wrist. So let's talk about the scaphoid. It's a funny bone. People describe it as a twisted peanut. There's two concavities in two different planes. It's covered by greater than 80% with cartilage, and it articulates with 5 bones in the wrist. The vascularity always comes up in testing scenarios, and I tried to highlight some of the ones that are more commonly tested. So the majority of the vascularity is retrograde from the dorsal carpal branch of the radial artery, and that's the distal 80% of the bone. And then the proximal, which is the more avascular section, can be supplied by branches from the volar, the superficial palmar arch, as well as the anterior interosseous artery. And you can see this image of injection studies, which commonly is in papers, that does show the lack of vascularity in the proximal pole. So in terms of thinking about non-union rates, these numbers definitely do come up in testing, and also is important clinically. You can see that it progresses as you get more proximal because of the pattern of vascularity that we just talked about. Okay, so talking about the actual bone and the ligamentous insertions that function essentially as deforming forces. Most notably, I would pay attention to the dorsal ridge where the scapholunate ligament attaches, as well as you have the volar stabilizing ligaments, the RSC, and the scaphocapitate ligament as well. And so this can come into play with fracture displacement, as well as provides the ligamentous stability in carpal mechanics. So I won't belabor carpal mechanics too much because I know we have a talk coming up about it. However, the important thing to know is that the scaphoid is the link between the proximal and the distal rows. And so when that disruption occurs, you lose the integrity of the carpal mechanics. So this was a patient who essentially has a transscaphoid perilunate injury, and just fixing the scaphoid essentially restores the normal carpal mechanics here, which is what you see here. And these are quite satisfying injuries to treat. Now, evaluating these patients, there's usually a fall and outstretched hand. Sometimes there's alcohol involved, sometimes not, but essentially there's pain on the radial side of the wrist. The problem is that there's lots of structures in that area, and you need to be very specific about your history and your physical exam. Here are some basic findings. It hurts to press on the snuff box as well as the tubercle of the scaphoid, and you can have pain with pronation, and also axial compression can also help out determining this. So as a differential, looking at pain on the radial side of the wrist, you have the scapholunate ligament, you have FCR pathology, either rupture or tendonitis, you have a fracture of the styloid, CMC or STT arthritis, Dequer veins, or even radioscaphoid arthritis. So you need to be very specific with palpation even, and sometimes I use the tip of a pen with the end clicked out to get a more accurate examination. Now, examining these patients with radiographs, I think the importance cannot be overstressed of having good x-rays And specifically, a lateral can be very helpful, not just for scaphoid fractures, but for other carpal pathologies. And I would just try to be aware of the fact that you want to get your pisiform over the distal pole of the scaphoid, which indicates an adequate lateral. And a scaphoid series sometimes is 4 or 5 images, but generally involves these imaging views that can help you fully evaluate. And most notably, the PA and ulnar deviation brings the scaphoid fully upright, so you can see the morphology of any fracture if present. This is a case example that sort of had equivocal findings on X-ray, but I had a high suspicion on physical exam. And so this brings up the whole topic of quote unquote occult fractures. And so I think what's interesting is that there's also no consensus in the literature about how best to manage this. Historically, bone scans have been used to identify them. I think that it's good practice to bring the patient back in a week or two for repeat X-rays, as well as if you're thinking about getting an a higher level imaging. MRI tends to be better earlier, and CT tends to be better later. So you can keep that in mind. However, there is a true risk of false positives. Oftentimes, vascular channels can be read as a fracture, and you should also take into consideration the cost to the medical system of routinely ordering these higher level imaging. If you do order imaging for the scaphoid, I would urge you to speak to your radiologist and make sure that you order it in the plane of the scaphoid with small cuts, generally 1 millimeter if you can, because that will give you better diagnostic accuracy. So a word about classification, which I think is generally more for research purposes. However, these are 2 of the more commonly reported ones. I think that the most important thing when you're looking at classifications is how it relates to clinical use. And I think that like we discussed, the more proximal the fracture, the higher suspicion you need to be and concern about non-union and greater trouble in the future. So speaking about union, you think it would be easy just to say, well, when the bone is healed, you're good to go. However, there's no real consensus on how to define this. And so some of the ways you can define it is clinically with tenderness and pain, serial X-rays. Some people use the definition of 50% of bridging bone on CT. The question then arises, though, how do you then correlate that to clinical situations? Okay, so treating these patients. Okay, I want to be very clear that most of these patients, most of these injuries heal without surgery. 90 to 95% of union has been reported with casting. Then the topic often comes up with, what type of cast? Historically, long arm cast with a thumb spica, and now we've sort of cut it all the way back to a short arm cast with no spica, and there hasn't really been shown to be any appreciable difference. And I think that this is definitely in a testing environment. That's all well and good, but I think that you also have to keep in mind who you're treating, and if you need more stability, then I think that that using a short arm cast with a thumb spike extension is reasonable. So now let's talk about surgery. This is the fun part. There is definitely a trend towards fixing more of these and fixing these earlier, with some data suggesting that there's earlier return to work and even earlier union. However, as I discussed, the definition of union is not widely agreed upon. And so I would just look at these studies with a cautious eye. There are some suggestions that there's cost effectiveness of operating on these to get people back to work sooner, which I think may be true depending on the patient's occupation. So we're happy. However, by the same token, you can find studies that report on the exact opposite. So this was a JBJS article in 2008 that essentially showed no difference when treating non-displaced scaphoid fractures. In fact, having slightly higher complication rate in the operative group. Now, if you'll notice that the STT arthritis can be a difference between clinical and radiographic arthrosis because of violating the STT joint to put the screw in. So speaking more about surgery, I think that indications wise, if there's significant displacement and there's a high likelihood of non-union, it makes sense to fix these. Specifically, you'll hear about humpback deformity, and that happens because of those deforming forces and the bony morphology that we spoke about. A couple of the angles that you may see in the literature and on testing scenarios is the radiolunate angle, which you can see here, as well as the intrascaphoid angle. And these are just ways to define and describe union. Clinically and practically, it's very difficult because these angles change based on the cut you're looking at in the scaphoid. So you need to be very diligent with your surgical indications here. In general, you're trying to get hardware, generally a screw, center, and you're trying to achieve absolute stability so we can get primary bone healing. As we know, the scaphoid tends towards non-union because of the fact that it's covered in cartilage, it's bathed in synovial fluid, and it has poor vascularity. So something that a study that I think did contribute to how we think about these injuries and how we talk to our patients was this article showing that the biomechanical stability of a scaphoid fracture with a central screw and 50% healing essentially has the same biomechanical properties as an intact scaphoid. So this at least gives us something that we can tell our patients about when to return to their sport. Now, just like any treatment, you know, the surgery does have complications, the main of which that are seen clinically and tested is generally related to screw penetration. Obviously, you have risk of non-union, infection, and obviously this screw on the bottom left didn't exactly achieve the goals of the surgery. So lots of different techniques. We'll go through them briefly. So this was a percutaneous patient, a percutaneous screw. I prefer, if possible, to go retrograde, just because I can extend the wrist, which helps with the reduction maneuver. This is, I'm using an osteotome here to remove the volar lip of the trapezium, just to get a better entrance point into the center aspect of the scaphoid. Here's the guide wire, and essentially straightforward. This is the screw after we're done. Okay, here's another patient that I'm sorry that the images are a little grainy, but I highlighted the fracture here, so it's kind of proximal third. And in the more proximal fractures, I do tend to go dorsal to get better trajectory of the screw and compression of the fragment. So this is just the surgical approach, a dorsal longitudinal incision, opening up the third compartment and retracting the EPL and entering the capsule. This is just a little technical point about a derotational wire that can help you with your trajectory, as well as to prevent any displacement intraoperatively. As well as some people do use traction on the thumb to help. I don't typically do this, but and then you can see using your K wires as joysticks to get your reduction. And now this image on the upper right is a semi-supinated view, and you can see that this image is good to see dorsal screw penetration. For volar approach to the scaphoid, this is generally helpful to correct humpback deformity, because you can insert your graft if needed volarly to restore the alignment, and therefore the alignment between the proximal and distal rows. Some other fixation options, the multiple screw fixation, I think has an important role, and Dr. Kim, who's on this panel, I think contributed nicely to this, as well as volar plating, which I think is a viable alternative. I think the jury is still out on indications, and I think that most of the trouble thus far has been to prominence of the hardware interfering with radiocarpal motion. And this is just an image showing sort of a watershed line that you need to be careful about when placing your plate volarly. And just in the interest of time, I'm not going to go through scaphoid non-unions too much. However, I'll just touch on it a little bit. This was a patient who fell, and basically he wore his cast when he wanted to, and came back 6 months later, essentially with a non-union. And this was the technique that I used to correct the alignment of the scaphoid, and therefore trying to get this bone to heal in the right position to restore alignment of the of the scaphoid and the rows. So in summary, hopefully I confused you more than when we started. Some of my mentors have told me that's the goal of a good education, is to confuse you more. But essentially for non-displaced waist fractures, I generally treat this non-op unless there's a good reason to do surgery. And then the type of immobilization I use is a short arm thumb spica for 6 to 12 weeks, depending on fracture location. And I typically get a CT around 3 months to determine union or return to sport. In displaced fractures, I tend to fix using a single cannulated headless compression screw. And I prefer antegrade for the more proximal fractures, and otherwise I prefer the retrograde technique. In summary, there's no real true consensus, and most of these heal without surgery, but it's important to individualize treatment when taking care of these patients. Thank you. And I'll pass off to Dr. Strouch.
Thank you. Thank you. Let me get this presentation done. There we go. Hopefully everybody can see that. We're going to talk about distal radius fractures. This was a true case. This was one of our senior residents in general surgery who was playing soccer. This was quite a while ago. He fell down in Central Park, and he was with our ortho residents. So they brought him into the ER, and he had this Colles comminuted type of fracture. So question is, what do we do? This is one of our senior residents at Columbia. Do we take him to the OR right away and fix it, or do a closed reduction? So his fellow residents did a nice closed reduction, and the right side is the broken side, left side is comparison. Looks pretty similar, maybe a tiny bit short. Lateral film looks quite similar. So now the question is, what do we do? He comes to see me in my office a few days later. Is the reduction adequate? I would say yes. Will it hold? Well, that's what we need to discuss. And does he need to be fixed? We'll discuss that as well. So he ended up non-operative treatment, and he did quite well. And although he was a little bit short, no symptoms, and he's currently the chief of cardiothoracic surgery. So he did quite well. So when we talk about distal radius fractures, you can basically fix all of them, even minimally displaced ones, which is an option. Or if you get a good reduction with a non-Barton shear type fracture, you could watch it. And if it makes it 3.5, 4 weeks, usually it'll be okay. And then you fix the ones that don't stay. So distal radius fractures are about 10% of all fractures, the most common fracture of the upper extremity, most common in young and older people. The normal anatomy, the AP film shows a radial inclination angle of 23 degrees, an ulnar variance of about neutral, with some variation, of course. The lateral film normally shows a palmar tilt of about 10 to 12 degrees. But you always want to x-ray the opposite wrist for comparison, because some people may be extremely ulnar negative or ulnar positive, and you, in trying to match a normal wrist, may be making their wrist abnormal for them. The AOS reduction guidelines for distal radius fractures are less than 10 degrees of dorsal tilt, less than 10 degree loss of radial inclination, which means it'll take it to about 13 or 15 degrees, less than 3 millimeters of shortening of the radius, and an intra-articular step off less than 2 millimeters. Now, the AOS, after reviewing many, many papers, could not recommend for or against operative fixation if you were much younger than I am, which is 55. There's also no need for early wrist motion, and that's key. You can lock up a wrist a long time, and at a year out, the results are basically the same in terms of wrist motion as if you had started it moving immediately. On the other hand, finger motion needs to start right away, because if you don't get the fingers moving, that will be a permanent limitation if they get stiff. We've all seen patients come back to the clinic 6 months later and you ask them to make a fist, and all they do is make a fist 50% of the way. Also, no type of fixation has proven superior. So they can't make a case for volar plates versus X-fix versus anything else you might want to try. Now, what about older people in distal radius fractures? Well, yes, most of them have lower demands and comorbidities, and if they have arthritis, well, they may not have as long to suffer with it, right? But a lot of them are not accepting of a cosmetic deformity. We have a lot of 80-year-olds that are still playing singles tennis, and they have friends that may have a crooked wrist. They don't want their wrist to look like that. They want a straight wrist. So you really need to talk to them that if you choose non-operative treatment and it ends up with a malunion, that they're going to be okay with that. And sometimes they say they're going to be okay at the beginning, and then they're actually not okay with it. Abraham Colles in 1814 said that, yes, you're going to have some deformity of the wrist, but it's going to be painless. So you don't really have to worry about it. And we know that's really not the case for many patients. This is a typical distal radius deformity with shortening, prominence of the ulna, and radial deviation. Now, Dr. Paxima and Egol and co-authors downtown did a nice study, distal radius fractures in the elderly, comparing operation versus non-op, and they found that the patients who were treated non-op were similar to those who had surgery, except their grip strength was better in the operative group at 1 year. This is a well-cited study by Aurora from Austria, where they did a prospective randomized trial comparing non-op with a volar non-op treatment compared to a volar locking plate for patients 65 years and older. Basically found no difference, although again, the grip strength was a little bit better in the operated group. This is a vast database study of over 13,000 patients comparing outcomes and complications, and they found that stiffness was significantly more frequent following operative management compared to non-operative treatment. This was from Rochester, Minnesota in 2019 JBJS. So the real life problem is when patient comes into your office and the residents have done a great job, or the PAs in the ER, they did a great reduction. They did it twice, in fact, because they wanted to be perfect. And it's okay. I mean, it looks all right, but we know that on the prior x-ray, before it was reduced, it looked pretty bad. So the dilemma is it may not hold, and over time the fracture may settle and collapse. And I've been using this nice analogy for many years of the smashed styrofoam cup. So here we are about to fall on our outstretched hand, probably drunk if we use Dr. Ayalon's patience, and it smashes. And then you go to the ER and they pull it out to length. And it looks fairly okay. But if you look closely, you'll see on the AP here on the on the left and on the lateral x-ray, there's missing pieces of bone, okay? And if this is an old styrofoam cup with kind of crumbly styrofoam, the chances that this is not going to hold are greater. And if there's more comminution or more missing pieces, the chances that it won't stay in place are greater. And so as time goes on and you make a fist and you compress the bone together, it's going to shorten a little bit until at the end, it may come back almost as bad as it was to begin with. That's why these fractures don't stay in certain cases. Now, there are some fractures that will never hold, like articular shear fractures, the volar and dorsal Barton's fracture that have a vertical fracture line. You can pull out, and that's great, but as soon as you let go, it slides back. Radial styloid fractures, same problem. So that's not going to hold if you just pull out and try to put a splint on that or a cast. What else is unstable? If it's comminuted, if they're very crunchy fracture ends, if it's old soft bone. So LaFontaine in 1989 wrote a small article that ended up being quoted quite widely, and they tried to find fractures that were going to be unstable. And this was published in the Journal of Injury. So if there were 3 or more on the initial pre-reduction x-ray, initial dorsal tilt, significant, greater than 20 degrees, dorsal comminution, intra-articular fracture, ulnar styloid fracture, or if you were older than 60, if you had 3 or more, the fracture was most likely going to settle and collapse. So if you have a perfect reduction and it's not a Barton's type fracture, you have 2 options. You can either say, all right, well, it might hold, it might not hold, but we can see you every week and a half or so. And if it does collapse, we'll fix it. And if it makes it 3 to 4 weeks, it's usually going to be okay. Or we can fix it just to ensure it stays in place. You don't have to worry about it coming. I don't have to worry about seeing you back and then having to squeeze you in the OR schedule. So there's 2 options, and both are acceptable. So why fix a perfectly reduced fracture? Just for those reasons. Also, the surgery is a little bit easier than if you get to it later and there's already a lot of callus forming and it's partially healed. Disadvantages of fixing things early, obviously, are the disadvantages inherent with any surgery. What kind of surgery to do? Well, we used to do K-wires and casting called pins and plaster, not done so much anymore. External fixation used to be our go-to method back in the 90s and the 2000s. Not done that much anymore. Plates, of course, that's our major go-to, volar locking plates predominantly, and combinations of the above. Now, plates and screws are mandatory for volar and dorsal articular shear fractures. Either a buttress plate or a locking plate is necessary. And of course, the volar locking plate is used for most types of fractures nowadays. What about the locking plate versus X-fix? Well, we did a study years ago showing that the locking plate recovers motion faster because you're moving it faster. If you have an X-fix on for 6 weeks, you're not moving the wrist. So at 6 weeks, it's going to be very stiff compared to if you get it moving at 2 weeks. But at a year, there was no difference in follow-up. And that was published in JBJS way back in 2009. Since then, there have been many studies showing that there's really no preferred method of fixing radius fractures. Now, disadvantages of plates and screws, sometimes the screws end up in the joint. So it's very helpful to check an angled lateral view to make sure that your screws are not in the joint. They can irritate the tendons, specifically the plates with the volar plates with long screws can hit your EPL and rupture that. And a prominent plate can rupture your FPL or the FDP of the index finger. Furthermore, the plate is not a panacea. It's not a guarantee of holding or healing the reduction. And so you have cases where things just don't work out as you thought. It's not a guarantee that everything's going to be fine. The Sung index is something you should know about. And this is a measure of how prominent the volar plate is. We don't want it to be too prominent, or it tends to rub on the FPL tendon in particular and may predispose to rupture. The more prominent it is, the more likely it is that the FPL may rupture. Here's one where you can see that screw sticking out, and this resulted in an FPL rupture. And if the FPL does rupture, you can take a tendon graft and do an intercalary graft if it hasn't been too long. But if it's been a long time, there are other options such as tendon transfer or just fusing the thumb IP joint in some flexion. And here's the stump of the FPL that was eroded on the plate. So you have to take out the plate and hardware and do a reconstructive procedure. Now, EPL rupture is seen with dorsal screw penetration from a volar locking plate. There's no need to be bicortical with the distal row of screws. It's fine to go 75% of the way across. And you should know that the maximum screw length is about 18 millimeters. If you're putting in a 24 millimeter long screw and it's not, shack, then it's too long. It shouldn't be longer than 18 millimeters long. You also see EPL ruptures with a non-displaced distal radius fracture. We're not sure how that happens, but it can happen a few months after treating a very minimal fracture. They'll show up with an EPL rupture. And both of those can be treated with an EIP to EPL tendon transfer. And those usually do quite well. You have to make that pretty much as tight as you can do it because they always stretch out. So they ask about EPL rupture on exams. It's seen either with non-displaced fractures or with prominent volar to dorsal screws. You treat with an EIP to EPL transfer. The FPL ruptures on prominent volar hardware, and you treat that with an intercalary tendon graft or tendon transfer, usually of the FDS of the ring finger to the FPL, although you can also fuse the IP joint. Now, external fixation still has a role. It can maintain the length of the fracture and neutralizes your finger flexion forces, but usually it's used as a supplemental technique these days. Now, if you just pull straight out on the hand, you're not going to restore your palmar tilt because your volar ligaments get tight before the dorsal ligaments. So as hard as you pull straight out, it's not going to restore palmar tilt. However, if you push the hand, and including that with the lunate palmarly, that can actually translate the carpus and improve your palmar tilt of the radius. So here, no matter how much you distract it, you're only going to get to neutral tilt, and maybe even not that. But if you push down on the hand and the carpus and translate the lunate palmarly, that will induce a force in the distal radius to try to make it a palmar tilt. Now, why do people's fingers get stiff with external fixation or any type of fixation or no fixation, just a splint? The reason is they didn't move their fingers. And that may be because they had a splint on that was too long and they couldn't, or they didn't know to do it, or they were told over and over to do it and they didn't do it because it hurt them too much and they just didn't really want to hurt themselves. And that was me back in 1983 in medical school. I love to show this. picture, always in my distal radius talks, because I actually had some hair back then. So anyway, I can tell you it is a little bit tricky to make a full fist with an external fixator on, but it's certainly doable, and it's not that hard. And so it is possible to make a full fist with that easily. Now, external fixation I usually use for salvage procedures now, such as when the volar lunate facet escapes around the plate and you have to redo the surgery. You can put an X-fix on to actually translate the hand dorsally, the opposite of what you would normally do for a reduction, and try to prevent resubluxation. So here was a case where the volar lunate facet escaped around the plate, and we redid the plate and put an X-fix on so I could sleep at night. And here we've translated the hand and the capitate dorsally, trying to pull the lunate dorsal so it doesn't exert a force to back out and retranslate. And you can see the capitate is riding a little bit dorsal here on the lunate, showing you that force that we put in before we locked in the X-fix. And that one stayed in place just fine. You can also put a dorsal spanning plate on, but the X-fix is only needed for 4 to 6 weeks, and then everything's healed up. So I didn't think a spanning plate was necessary in this case. So a dorsal spanning plate is really an internal external fixator. A lot of people use it for many different indications, but it does need to be removed, and there's sometimes tendon ruptures that can happen with it. And so I'll usually use it in a situation where I need to keep fixation solid for 3 months or more, and then take it out. And so here's a nasty radiocarpal fracture dislocation that occurred. That's the kind of thing that I'll use it in. What about fractures of the ulnar styloid? So a fracture at the base of the ulnar styloid, a big piece, destabilizes the DRUJ because the TFCC attaches to the foveal area and is the main stabilizer of the DRUJ. So if you have this big chunk, the whole TFCC is attached to this piece. And yet, after you fix the radius, most of these are still associated with a stable DRUJ, surprisingly. So what you need to do is, when you fix the radius, then you assess the stability of the DRUJ by trying to shuck it in and out. Most of the time it's stable, you don't have to fix the ulna, but if it's unstable, then you can fix that ulnar styloid with a small incision. There's many ways to fix it. I usually use a K-wire and then drill a hole through here and wrap a figure of 8 fiber wire type around that pin, and that works okay. And one of the reasons why the DRUJ may be stable even with no TFCC holding it, such as with that ulnar styloid base fracture, is that there's this thing called the distal oblique bundle of the interosseous membrane, and that is tension when the radius is brought out to normal length, and that may stabilize the distal ulna even in the absence of a competent TFCC. A few other points. First of all, people, I don't care what kind of fracture you have, non-displaced, minimally displaced, major problem, it's very hard to do push-ups in the usual way or the yoga downward facing dog after a broken wrist. And so for a long time, if you like push-ups, do them on your knuckles, but I would recommend using a pad and not doing them directly on a hardwood floor like that. Second thing is, it took me 6 months to be able to get full supination back. And so I tell patients, if they're struggling at 6 weeks, not getting full supination, don't sweat it, because eventually, if you keep working at it, assuming that the bony anatomy is relatively okay, it should come back, usually. And it always hurts pretty much on the ulnar side of the wrist when you're deviating, and maximum supination and pronation hurts for quite a long time, because basically all these displaced fractures are associated with a TFCC tear, even if there is no ulnar styloid fracture. They also ask about vitamin C. There were some studies showing vitamin C, 500 a day, prevents CRPS. That's largely been debunked, but sometimes they ask about that. Routine hand therapy, meaning for like every person that has a wrist fracture, is not necessary, but it is mandatory if their fingers are not moving 100%, I think, right away. If they don't have 100% motion of their fingers right away, I send them to therapy for finger motion. And it's also helpful to check and send them for osteoporosis, for bone density testing, because this is the harbinger of worse fractures to come in older people. Questions that are associated with distal radius fractures on the in-service, they like to ask about this. What happened here? And this is volar subluxation of the carpus after fixing a radius with a plate. And the answer is the plate did not adequately capture the volar lunate facet of the radius. Here's a question. This is a 50-year-old man who sustained a wrist injury after a motorcycle accident. There is no DRUJ instability after radius fixation. Management should include fixation of the radius. Okay, you see that there's a Colles fracture and there is a reasonable ulnar styloid fracture. So should you fix the radius alone? Should you excise the ulnar styloid, repair the TFCC, percutaneous fix the ulnar styloid, or do ORIF of the ulnar styloid? And the answer is that the stem is that there's no DRUJ instability. So stop. It's stable. That's it. Don't do anything else. This is a CT scan of a 45-year-old woman who injured her wrist after a fall. Appropriate treatment of the fracture should include cast immobilization is not going to do it. Closed reduction percutaneous pin fixation, not going to do it. ORIF and volar lock plating, well, that's sort of appropriate, you would think. ORIF and radial styloid column plating, no, this is on the ulnar side of the radius. Or ORIF and fixation of the volar fracture fragment. Now that's a better answer because that's really what you want to do. You don't really need a volar plate for this. The volar plate's going to be over here. It's not going to capture that piece. This isn't really a great question because there are some volar locking plates, of course, that will capture this. But the best answer is ORIF and fixation of the volar fracture fragment. 42-year-old woman is treated with a cast for minimally displaced distal radius fracture. So you're already thinking they may have ruptured their EPL, sustained 3 months ago, develops a sudden inability to extend the thumb IP joint. How are we going to treat it? Well, you can fuse the IP joint. That's an acceptable answer, but it's only been 3 months, so it's reasonable. She's young, so it's reasonable not to do that as a first step. Evaluation for PIN palsy, that's unlikely if it's only a EPL problem. Primary repair of EPL tendon, usually not possible because these usually kind of rupture and the ends are mop ends and they're not fixable primarily. So the answer is for EIP to EPL tendon transfer. Fixation failure of which comminuted distal radius fracture fragment is associated with volar subluxation of the carpus? And the answer here, as we've talked about, is the volar ulnar side. Which factor is a validated predictor of fracture displacement following closed reduction of a distal radius fracture? Age, gender, radial inclination, short arm cast. The answer is usually older people have worse bone and they tend to fall out of place. While attempting to recreate the inclination of a distal radius during volar fixation of an intra-articular fracture, use of fluoroimaging in this position would be helpful in showing, and they're showing you an angled view where you're going to be able to see down the slope of the radius. Remember, the AP film of the radius has a 23-degree angle, right? So if you bring it this way, you'll be able to see down the slope of the radius and you'll be able to better see any screws that might be intra-articular, which is the answer. 35-year-old man has a markedly displaced radius fracture, has closed reduction. It looks good in a sugar tongue splint with the wrist in 5 degrees, so not much flexion. You know, we don't want to put the wrist in a lot of flexion for our splints. 18 hours later, he comes back to the ER with pain and numbness. He can't feel anything, and the forearm is soft, minimally swollen, and tender. So what's the next best step? So now he's got severe carpal tunnel syndrome pretty quickly after your reduction maneuver, which was not excessively flex. So you're not going to, an answer of just redoing the fracture position is not going to be the correct answer. Do you want to admit and observe? That's not going to do anything. Fracture repair and carpal tunnel release, that makes sense. Fracture repair and fasciotomy doesn't make sense. His forearm compartments are soft. But you want to change the sugar tongue and put him into extension, and that's not going to do anything either because he really wasn't flexed significantly. So the answer here is fracture repair and carpal tunnel release. For enclosed reduction of a Colles fracture, which maneuver in addition to traction will likely provide the best reduction? And we talked about this. This is volar translation of the lunate by trying to press down on the metacarpals, basically, or the dorsal carpus. Figures 1 and 2 show volar plating 8 months prior. Patient cannot actively extend her thumb for 2 days. You can see this screw is a little bit prominent here. And what's the best treatment? Answer, EIP to EPL tendon transfer. Removal of the hardware and EIP to EPL transfer. You got to remove the hardware, otherwise it's going to rupture your other extensor tendons. And here's the last one, I think. 82-year-old woman with osteoporosis. 8 weeks ago, she fell and fitted herself with a removable wrist splint. She has no pain. She can dress herself. She prepares meals. She does everything without problems, but she has an obvious wrist deformity and only 70 degrees of wrist extension, which is actually better than me. And that's because it's it's dorsally tilted. She can make a full fist and she can fully move all her digits. What's the best treatment? Well, you could do a radius osteotomy, but you'd be treating the x-ray. And if it didn't work out well, she would be very unhappy with you because she can do everything that she wants. And she's 82. So the answer is to observe it. Thank you very much. And now we will introduce Scott Wolf, who is a man who needs no introduction, from the Hospital for Special Surgery. And he is an international expert on wrist instability, a very difficult topic, which I'm sure he will make easy to understand.
Thanks, Rob. Let's just share my screen here. Can you see that, Rob? Good to go?
No, we're not seeing your screen. I see you.
How about now?
It's starting. Yeah, there we go.
All right, well, thank you. And good morning to everyone in this group. Over the next 20 minutes, I'll blur through a whole bunch of concepts in carpal instability. While I have several corporate consulting agreements, none will have any bearing on my thoughts on carpal instability. And over these 20 minutes, I'll try to shed some light on what's old, what's new, and what remains a total mystery to those of us in this arena.
Scott, sorry to interrupt. We can't fully see your slides. The left side is cut off.
I don't know what to do about that.
Oh, now I can. I'm sorry. Okay. Can everybody see okay? Okay, just go on.
Can you see? You're not seeing my split screen. You're seeing the wrist instability, right?
No, yes,
With the definition?
correct.
Okay.
No,
Perhaps it's being broadcast over the wrong camera, but anyway, okay. Is that better? See everything?
yes.
All right. So to begin, we need to agree on a definition of the sometimes confusing term wrist instability. Sanj Kakar and I agree that wrist instability is a symptomatic condition involving abnormal carpal bone motion during loading activities of the wrist. All of those elements are important. I mean, as we all know, we've seen wrists out of position that aren't even symptomatic. So it has to be symptomatic, it has to be during loading and activity. And let's pique your interest by starting off with an OITE question. This 27-year-old female presents with these radiographs 8 weeks after open reduction internal fixation of a scaphoid fracture. You suspect which type of carpal instability? Give you a few seconds to read the answers. And think about this over the next 15 minutes because the answer will be there. So understanding the three bones of the proximal carpal row and their ligamentous connections is vital to understanding carpal pathology. These three are the only truly mobile bones of the carpus, as the distal carpal row is rigidly fixed to the hand and the forearm is the remainder. They're inherently unstable and they're guided by their articulations proximally and distally and the ligamentous constraints within. Over the past 100 years, two main theories of carpal bone kinematics have evolved to describe the wrist as organized into proximal and distal rows or as three linear columns. Both of these theories arose predominantly from two-dimensional radiographic studies of planar motion, that is, flexion extension and radial ulnar deviation. Because of the complex three-dimensional motion of the carpus and the coupled or dart-throwing motions required for most activities, many investigators have concluded that both theories are too simplistic to adequately describe carpal kinematics during wrist function, and that functional wrist kinematics requires combinations of both. What is the intercalated segment? Landsmeer's eloquent 1961 paper furthered the idea of an inherently unstable link by describing the intercalated bone as one whose motions are entirely governed by its neighboring segments, like the segments of a wooden snake. His work was illustrated by the stacked phalanges of our digits and can equally well be visualized in the central column of the wrist. Linscheid and Dobbins expanded Landsmeer's concept of the intercalated bone in this 1972 landmark article by including the neighboring triquetrum as an intercalated segment rather than intercalated bone, at once rigidly connected but inherently unstable. This concept furthered the now widely accepted carpal row theory of kinematics that was actually proposed by Disto nearly half a century earlier. There are no tendon insertions on the intercalated segment, Thus, its motion is entirely dependent on mechanical signals from the distal carpal row. As the hand unit moves, it follows passively. All bones of the proximal carpal row move together, albeit to different degrees, and limited by a set of surrounding ligaments. The scaphoid coordinates its motions through the tight interosseous scapholunate ligament. Critical to an understanding of the kinematics of the carpus is an understanding of the ligaments of the proximal carpal row, as all instability patterns are manifested as abnormalities of proximal carpal row motion. As Dick Berger demonstrated 20 years ago, the scaphoid and lunate are the key players of the proximal carpal row and are linked together by a complex scapholunate interosseous ligament made up of 3 component parts, of which the dorsal is the strongest. The ligament is vulnerable to injury with a fall in the outstretched wrist, which can tear all or part of this important structure. It should be thought of as the ACL of the wrist. The so-called secondary volar supporting ligaments of the scaphoid and proximal carpal row include the radioscapocapitate, the long and short radiolunate ligaments, and the STT ligamentous complex. The tight envelope of the scaphoid's interosseous, volar intrinsic, and volar extrinsic ligament support system is demonstrated here. The dorsal intrinsic and extrinsic ligaments are equally important counterbalances to the volar ligament complex and include the important dorsal radiocarpal and the dorsal intercarpal ligaments. Steve Vegas emphasized the clever oblique orientation of these ligaments, which, like an accordion, expand and contract with rotations of the wrist. In addition, Berger and Doyle described the dorsal scaphotriquetral ligament, the exact location or function of which was never really clarified. In this drawing, the DST is incorrectly portrayed proximal to the DIC. We feel that this critically important structure has been largely overlooked during the past 2 decades. We refer to these 3 ligaments collectively as the dorsal ligament complex. This shotgun exposure of a human wrist demonstrates these relationships and the unique labral-like arch that the dorsal scaphotriquetral ligament creates for the nearly acetabular receptacle of the midcarpal joint. In this inset, viewing the dorsal wrist axially, the DIC can be lifted to demonstrate the deeper and very stout dorsal scaphotriquetral ligament, inserting on the distal waist of the scaphoid. Lauren Wessel spent the better part of her residency characterizing the anatomic and histological attributes of this seemingly important ligament by doing dozens and dozens of cadaveric dissections. We'll now try to explain the maze of ligament instabilities with a somewhat simplified and logical classification system. Weber's work was instrumental in understanding how the mechanical signals from the distal row regulate the motion of the proximal row. With all ligaments intact, the lunate is delicately balanced by competing flexion extension forces on either side. In our first fully segmented video of a live human wrist in 1998, we can see the uninjured proximal carpal row moves as a unit in both flexion extension and radial arm deviation, guided by the scaphoid. But Guilford had recognized decades earlier that detached from the scaphoid, the central column was stable only in traction. The scaphoid link was thus critical to prevent collapse under load. Fisk later illustrated that concept with the effect of waist fractures of the scaphoid. Intact, the proximal carpal row and the central column of the wrist are in kinematic balance. With disruption of the scapholunate ligament or the scaphoid waist, the scaphoid is separated from the proximal row, initiating the slide into the first major class of carpal instability, so-called dissociative carpal instability. And the inexorable slide into rotational instability, postural changes of the scaphoid, postural changes of the lunate and the attached triquetrum, or DZ, dorsal intercalated segment instability, and ultimately degeneration and slack arthritis. Unlike slack wrist, ligament attenuation or rupture is not necessary for the development of the humpback scaphoid and DZ of snack wrist, scaphoid non-union advanced collapse. As Watson described this 30 years ago, a predictable and relentless pattern of degenerative arthritis ensues, generally sparing the proximal scaphoid and the lunate. The best defense against snack is to prevent it by early surgery on scaphoid non-unions. A similar situation can occur with traumatic disruptions on the ulnar side of the wrist. With disruption of the lunar-triquetral ligament, scaphoid and the lunate eventually tip into flexion, or VZ, so-called volar intercalated segment instability. Thus, 2 major classes of carpal instability can be defined by the site of ligament injury, either within the proximal carpal row or between the rows. Non-dissociative instabilities are more difficult to understand and reproduce. Carpal instability non-dissociative, as defined by the Wrist Investigators Workshop, is a general class of carpal instability. It does not involve a break in the proximal or the distal row, involves ligaments spanning the radiocarpal and the midcarpal joints, and might better be termed proximal carpal row instability because, again, the only bones of the carpus that move are the proximal carpal row. It has multiple etiologies. Most often, SIN presents in individuals with ligament laxity, and a snapping or clunking proximal row is demonstrated by the midcarpal shift maneuver on the right. In this article by Allison Kate, we provided a framework for classifying SIN, including the broadly used misnomer midcarpal instability, sorry, David Lickman, as the largest group. The clipped dorsal variety is described by Dean Lewis 40 years ago. The rare combined SIN, as seen in young kids and systemically lax individuals, and the common adapted deformities as seen in distal radius fractures or Madelung's deformity. The common denominator of all of these is that the entire proximal row, not just the midcarpal joint, moves abnormally as a unit without a break in the proximal row. To these four, it's become apparent there's a fifth variety of SIN that occurs following trauma, including both distal radius fractures and scaphoid fractures. In a collaborative study with Mark Ross and Greg Cousins from Australia, we've identified 8 cases of post-traumatic non-dissociative DZ and VZ with confirmed intact scapholunate and intertroquetral ligaments, and MRI or arthroscopy that confirmed the identity of the ruptured extrinsic ligaments that enabled the lunate postural change. Like boats in a harbor, which need both bow and stern mooring lines for a hurricane like Ian, the lunate has flexible dorsal and palmar tethers that stabilize it through an incredible range of motion and applied loads. Disruption of one or both of the volar dorsal combinations allows the lunate to tip in a reciprocal fashion with the rest of the proximal carpal row. Disruption of the opposite combination allows the lunate and the proximal row to tip into VZ. The third and final class, carpal instability complex, doesn't fit into a tight scheme, but rather represents different combinations of ligament and bony injuries. Transverse carpal instability or translational deformities of the carpus, most usually ulnar translation deformity, are massive injuries to the extrinsic ligaments of the proximal, crossing the proximal row. Combined injuries can be illustrated by perilunate or lunate dislocations, and longitudinal or nasty injuries, somewhat like Lisfranc fractures of the foot that divide the carpus in half along the lines of a metacarpal. They usually include nerve injuries and vascular injuries and can be very serious. So when faced with radiographs like this, there's almost, and pardon the pun, a dizzying array of repairs available to treat scapholunate ligament injury. What's important to understand is that despite dozens of creative surgical techniques over decades, there's frustratingly little evidence that we've moved our overall success rate forward, no single repair that provides uniform success, and no consensus or guidelines available to help us choose amongst them. So what initiates the degenerative change of SLAC arthritis and how can we prevent it? Is it rotary subluxation of the scaphoid? Is it gap or diastasis? Or is it DZ? You're right, it's scaphoid dorsal translation. In 2 recent studies, we've demonstrated statistical association between scapholunate ligament rupture and translation of the scaphoid onto the dorsal rim of the radius. With that, the midcarpal joint is disrupted, breaking that acetabular container of the capitate and allowing it to drift dorsally. Its dorsal moment accentuates the tendency of the detached intercalated segment to just tilt dorsally, and the scaphoid's dorsal rim position leads to rapid cartilage loss. We thus question Watson's nested spoons analogy and propose instead that the scaphoid, that symptomatic patients have more than rotational instability of the scaphoid. In fact, dorsal scaphoid translation is very easily detected on true lateral radiographs in relationship to a line through the dorsal rim of the scaphoid facet. It's also the only radiographic parameter that correlates with patient's pain following scapholunate ligament repair or reconstruction. The articular surface of the distal row is at once elliptical in the coronal plane and spherical in the sagittal plane because of its obliquity to the acetabular receptacle of the proximal carpal row. This is magnificently illustrated by a Shao-Moritomo schematic of the oblique axis of the midcarpal joint. Unlike the orthogonal and arbitrary planes of flexion extension and radial ulnar deviation, the midcarpal joint enables the coupled motions of radial extension to ulnar flexion, or the so-called Dart-Thor's plane of motion. In 2005, we demonstrated that the proximal row is nearly still during this important arc of motion. Work at our institution and many others demonstrated that nearly all complex motions of household, occupational, and recreational activities occur predominantly through the mid-carpal joint. Through collaborative work with anthropologist Mary Marsky and colleagues at Arizona State University, we proposed that Dartoro's motion was unique to humans and may have conferred a survival advantage to early hominids during the transition from tree-dwelling herbivores to ground-dwelling omnivores. Further anatomic study on cadaveric wrist demonstrated that the physiologic axis of wrist motion lies not in the anatomic planes of flexion extension and radial innervation, but rather in an oblique plane from radial extension to ulnar flexion or dart throwing. So our primary goal of scapular ligament repair and reconstruction is to restore mid-carpal architecture and function. And that's evidenced by the containment of the mid-carpal joint by reuniting the proximal carpal row and, most importantly, eliminating dorsal scaphoid translation. So why can't we get this right? We continue to struggle with our outcomes of scapular repair and reconstruction, as Julie Adams and colleagues illustrated in this review of 82 wrists followed retrospectively. They showed in this paper there was a 20% failure of ligament repairs and reconstructions at 6 months, and that at 6 weeks, a TLT or triligament adhesives was equally effective to a primary repair. That the primary repairs after 6 weeks, at least in their hands, did not work. So how can we improve the treatment of scapular instability? We need to understand its etiology. It's been taught to us by Short, Palmer, and many other investigators that the primary problem is the loss of the joint couple, as evidenced by diastasis of the scapular joint and failure of the scapular ligament, followed by secondary rupture attenuations of the secondary, so-called secondary restraints. But which ones? Are they STT ligaments, the volar capsular ligaments, the dorsal ligament complex? We really didn't know. A 2019 cadaveric study by Alfonso Perez from Chile and our lab demonstrated that scapular injuries alone do not cause DZ, that division of the long radial lunate, the STT or the DIC lunate attachments cause statistical increases in radial lunate angle, but that DZ was created only when the STT or the complete DIC were divided in addition to the scapular osseous ligament. We now refer to the STT, the long radial lunate, and the dorsal intercarpal ligament as critical stabilizers of the carpus, rather than secondary stabilizers. I don't have enough time to elaborate on the effects of ligament section on gap, scapular angle, and dorsal translation, but what seems to be becoming apparent is that the various postural abnormalities of the carpus may be dependent on injury to different critical stabilizers. As we continue to search for the ideal scapular repair, we should consider gaining a detailed inventory of injury to additional critical stabilizers using either MRI or arthroscopy and customizing our repairs accordingly. With so many creative repairs from so many in so many different institutions and different classes, we should start to consider an individualized approach rather than the traditional one-size-fits-all approach to dissociative carpal instability. Have we been concentrating on the wrong parameter of scapular dissociation all along? It's more than a gap. From Adelaide, Australia, Michael Sandow's novel reconstruction addresses not only the gap, but reconstructions each of the critical ligaments of the carpus. The technique uses a 3 centimeter flexcarpal radialis tendon graft based distally and reinforces it with a 2 millimeter synthetic tape. Each pass is anchored after tensioning to avoid stress relaxation. I've now switched to this technique for most of my difficult reconstructions with DZ and DST and have a successful cohort of 20 cases that we just reported on in Boston. Our video of the technique is available on ViewMedi, HSS video, and the ASSH video library and YouTube under NFM. It may be time to retool our diagnosis and treatment of scapular instability. Diagnosis should include an inventory of all injured structures using arthroscopy and or high-resolution MRI, followed by staging and targeted treatments of the particular injured ligaments. So now it's time to test your recall. Which is it? Correct. This is non-dissociative VZ. I'd like to thank you for your attention. That was a lot of information. I'm available to answer questions. Many thanks to the literally dozens of my colleagues at HSS and around the globe who've contributed to all of this and to helping me understand this most fascinating topic. Thank you very much.
Next, we have Dr. Martin Posner.
So Richard, okay, he's ready. Great. I was going to say I'm available for questions. I probably finished a little bit early.
Can you see my slide?
We can see you, but we can't see your slide.
Huh. Hmm.
The share screen on the lower bottom, the green.
Let me go out of this then. Let's see.
If you bring your pointer down to the lower column, you should be able to see share screen in green.
No, I don't see it. What do you think?
Okay, we're starting to see it.
Do you see it now?
We see it now, correct.
Thank you. Let me go back. So I want to talk about the extensor tendon mechanism and anatomy and pathology. And I'm going to cover the anatomy, the intrinsic paralysis. Dr. Dillons did a wonderful job on describing the mallet finger. And I'll briefly discuss that together with swan neck deformities and then with the boutonniere deformity. So the extensor tendon mechanism receives contributions from both extrinsic and intrinsics. If we just look at the contribution of the extrinsics on a finger, the primary extensors of the MP joints are the EDC, and for the index and little fingers, as you know, there's a proprius tendon as well. Those are the primary extensors. And the primary flexors are the FDS and FDP. So when the extrinsics contract with no other force acting on the finger, the result is clawing. Clawing is commonly referred to as the intrinsic minus hand because there's no effect of the intrinsic muscles. The pathology is always neurogenic, whether it's an injury or a neuropathy. And there can be clawing of all the fingers due to median and ulnar nerve pathology, which is common. Remember that the ulnar nerve can innervate all the intrinsics by a nerve connection in the palm called the Riche-Cadoux connection. It's a connection and not an anastomosis since nerves don't have stomas. Clawing requires a functioning profundi, and that's why clawing is much worse with a low ulnar nerve lesion than a high injury. And it also requires supple joints, meaning that MP joints that passively hyperextend. In those individuals who are tight jointed and have little or no passive extension of their MP joints, there's little or no clawing. So if this are the extrinsic effects on a finger, what's missing? We need something that is the primary flexor of the MP joint, and those are the intrinsics. And we need extensors of the interphalangeal joints. The intrinsics are not the primary extensors because the extrinsics also have a role. Normally, our MP and IP joints flex together. Without the intrinsics, there is no primary flexor of the MP joints. Therefore, the MP joints can only flex after the IP joints, and the fingers actually roll into the palm, and that obviously interferes with grasping larger objects. The intrinsic linkage between the flexors and extensors, the lateral bands pass volar to the MP joints and dorsal to the interphalangeal joints. With only intrinsic function, there's MP flexion and IP extension. And this is a patient who had a Volkmann's ischemic contracture of the intrinsic muscles. He was a hemophilic who had a compartment syndrome of his hand for which treatment was delayed. And this is commonly referred to as the intrinsic plus hand. Remember, the intrinsics extend the interphalangeal joints, and the extrinsics also extend them via the central tendons often called the central slips. The extrinsic contribution to finger extension is via the sagittal fibers and central tendons. And the intrinsic contribution is via the transverse and oblique fibers and the lateral bands. So there are sagittal fibers and transverse fibers. They're contiguous with each other, but have very different functions. The sagittal fibers are part of the extrinsics, and they go volar, exert on the volar plate, and extend the MP joints. And the transverse fibers are part of the intrinsics, and they flex the MP joints. So the extrinsics are the primary extensor of the MP joints, and they're primary flexors of the PIP and DIP joints. The intrinsics are the primary flexors of the MP joints, and they also extend the interphalangeal joints. However, the extrinsics can also extend those joints, provided they don't hyperextend the MP joints. So a favorite question I have for the residents is, what extends the interphalangeal joints? And typically the answer is the intrinsics. It's also the extrinsics, but you have to add the word provided they don't hyperextend the MP joints. The orientation of the sagittal fibers varies with positions of the MP joints. With the MP extension to neutral position, the fibers are perpendicular to the axis of the MP joint. In hyperextension of the MP joint, those fibers are almost horizontal, and the extension force is only at the MP joints. In that position, the central tendon is lax, and there can't be any active extension of the PIP joints. With MP flexion, the sagittal fibers are oblique and distal to the axis of the MP joint, and the extrinsic EDC, together with the EIP and EDQP of index and little fingers respectively, can pull through to the central tendon and therefore achieve PIP extension via the extrinsics. Intrinsic paralysis, or the intrinsic minus hand. The most predictable treatment depends on an important clinical test. It's with blocking of MP extension permits the extrinsic extensors to pull through to the central tendons and extend the interphalangeal joints. It's referred to as the Bouvier maneuver, named for a French orthopedic surgeon in 1851 who observed it in a patient with ulnar palsy. A favorite question I have is, to what degree does MP extension have to be blocked for the extrinsics to pull through to the central tendons and achieve PIP extension? The answer is just enough. There is no specific degree. It can be as little as 0 degrees or 10 degrees, or it may be more. The Bouvier maneuver requires normal central tendons that are not attenuated. If they're slightly attenuated, MP extension has to be blocked to a greater degree. Now, blocking it up to 30 or 35 degrees is okay. But if the central tendons are severely attenuated, and you have to block the MP joint to 45 degrees or more to achieve extension, that's not okay. You're changing one problem for another problem, and now you're causing flexion contractures of the MP joints that could interfere with function. So chronic clawing leads to central tendon attenuation, and therefore, following an injury or a neuropathy, it's important not to ignore clawing. A worthwhile splint to provide is referred to as a lumbrical bar splint, which simply blocks MP extension. And it blocks it to a point sufficiently to permit the extrinsic central tendons to extend the PIP joints. And the therapist makes this splint by just measuring with a goniometer. At one point, MP extension has to be blocked. And you could see in this individual, it's really just blocking the hyperextension, and you don't have to even put it into any flexion. For surgery for chronic clawing, when it's too late for a nerve repair, or a nerve repair was unsuccessful in restoring intrinsic flexion, a very predictable operation is a volar capsulodesis of the MP joints, originally described by Zancoli, which mimics a lumbrical bar splint. So simply, the MP joints are flexed to positions that permit PIP extension via the extrinsics, determined by the Bouvier maneuver. And at surgery, the volar plate is advanced approximately into the metacarpal head. So here's an 18-year-old female with Charcot-Marie tooth disease who had severe clawing, and it only required blocking her MP extension slightly for her to actively extend her interphalangeal joints. Planning for a volar plate capsulodesis is not a difficult procedure. Based on the preoperative examination, we want to stabilize the MP joints, maybe a few degrees more than that test showed, and with a goniometer during surgery, determine that degree and pin the MP joints in that flex position. The membranous portions of the plates are then elevated and sutured into necks, and suture anchors work just fine. So here's the preoperative picture and the postoperative picture, which looks pretty good. Remember, chronic clawing results in attenuation of central tendons. And when the Bouvier maneuver requires the MP joint have to be blocked more than 40 or 45 degrees or even more, then a Zancoli procedure is not effective. It can be effective, but you're producing a flexion contraction of the MP joints, which is another problem. This talk is in a very extended version on the ASH hand site, and we'll discuss what you do if a Zancoli procedure would not be indicated. And I discuss intrinsic transfers, but I don't have time in this morning's lecture to do that. Dr. Nellens covered this this injury very well of a mallet finger. And there are two mechanisms of injury: an axial force on the tip of the finger, where you get flexion and you get injury to the terminal extensor tendon with or without an avulsion fracture, or it could also be due to DIP hyperextension, where you get an impaction fracture at the base of the distal phalanx. There are a number of different classifications. I like the Tubiana classification of 1986 because it helps me in determining what to do. Type 1 is a tendon rupture. Type 2 and 3 are fractures, avulsion fractures with or without subluxation. And as Dr. Nellens pointed out, it's not important to determine the size of the fracture fragment. Naturally, the bigger the fracture, the more likely the subluxation, but that's not always true. And type 4 is the epiphyseal plate fracture. For type 1 injuries, which are the most common, all you need to do is splint the DIP joint. It's unnecessary to splint the PIP joint. And I would caution you not to use the froggy splints because they consist of these aluminum tabs being pushed against the finger. And I've seen a number of patients with skin necrosis. The splint can be dorsal, volar, or a commercial splint like the stack splint, which is a combination of dorsal and volar. My preference, I like dorsal splits. They interfere less with use of the hand, and they're easy to change while maintaining extension of the joint. Naturally, when you want to change the splint or want to cleanse the dorsum from the skin, you can't allow the DIP joint to flex, otherwise you're starting from day one. With a bony avulsion fracture, the question is there subluxation or not? And if there is subluxation, then these should be treated, as Dr. Nellens pointed out. The swan neck deformity is a description, not a diagnosis, of PIP hyperextension and DIP flexion, which resembles the neck of a swan. It can be normal in some loose-jointed individuals who are able to contract their intrinsics without contracting their extrinsics. There are many etiologies of swan neck deformities. It could be due to intrinsic muscle contractures, as in an inflammatory arthritis, a volar instability of a PIP joint, in Ehlers-Danlos syndrome, in CP spasticity in the stroke hand, and other diagnoses as well. The diagnosis of just writing swan neck deformity does not provide any information as to etiology. So to use the deformity in a diagnosis, you should always add due to. For instance, you can say swan neck deformities due to intrinsic contractures, or swan neck deformity due to volar instability of the PIP joint. The boutonniere deformity, which curiously is only referred to as a boutonniere deformity in English-speaking countries, because in French-speaking countries, it's referred to as deformité buttonhole. Don't ask me why that is. I've asked my French colleagues about that many times, and I've never gotten an answer. So the radial and lateral bands become edges of a buttonhole. Normally, with a PIP flex 90 degrees, we're unable to actively extend the DIP joint because the central tendon in the PIP flexion of 90 degrees is pulled distally, and the lateral bands are lax. And therefore, with MP flexion, you can extend the DIP joints, but not just with PIP flexion. The Elson test is positive in an acute boutonniere. With PIP flexion, the DIP extends, and it's due to the lateral bands pulled proximally and subluxated vola to the PIP axis. I generally don't use the Elson test except when around the hand fellows, because I just want them to let them know that I know what it is. Classification of boutonniere deformities can be acute, subacute, and chronic. The acute boutonniere deformity is unfortunately often missed. There can be swelling and tenderness of the dorsum of the PIP joint, which can be the only clinical signs. And you need an index of suspicion when evaluating PIP injuries. If there's tenderness over the joint or slight swelling, you should treat it and splint the PIP joint in extension. What unfortunately happens is these injuries are seen in an emergency room, the x-rays are normal, and the patient is told to, at some point, see their family doctor, and weeks later, they show up with a severe and chronic boutonniere deformity. Active extension of the PIP joint can be complete or nearly complete when the injury is limited to the central tendon, meaning the triangular ligament is intact and the lateral bands have not shifted vola to the axis of motion. So if someone took an 11 scalpel blade and just cut the central tendon, you probably would not get a boutonniere deformity because the lateral bands would not shift. When in doubt, split the PIP joint in extension and reevaluate within a week. What's important is the retinacular ligament, of which there are two components, a transverse component and an oblique component. With the PIP flex, the oblique retinacular ligament is in a relaxed position, and when something is in a relaxed position, either ligaments or tendons, they can undergo contractures. And the result is you not only get limited DIP flexion, but also wind up with an extension contraction of the DIP joint. Therefore, it's important to prevent contracture of the oblique retinacular ligament. Splint the PIP joint in full extension. Do not splint the DIP joint. And the original splint was made by Sterling Bonnell, and it was called a safety pin splint because he made it out of a safety pin for a horse blanket. A more effective splint is made by hand therapists, which immobilize the PIP joint, not the DIP joint. It's important that patients begin active and even passive DIP flexion. Surgery is generally unnecessary for the acute closed boutonniere deformity, and the only exception would be a central slip avulsion with a bony fragment, which is not very common. I will prefer to fix these with a intraosseous wire that's passed under the lateral bands and through the middle phalanx. What's the difference between a boutonniere deformity and a pseudo-boutonniere deformity? They occur on different sides of the joint. A boutonniere deformity is an injury to the extensor tendon mechanism, the central tendon and lateral bands, while a pseudoboutonniere deformity refers to a flexion contracture of the PIP joint. There's been no primary injury to the extensors. For the diagnosis, don't look at the PIP joint, but look at the DIP joint. When there's limited or no active flexion of the DIP joint, the patient has a contracture of the oblique retinacular ligament, which is very common in chronic boutonniere deformities, and the patient is unable to flex the DIP joint. Here's a case of a pseudoboutonniere deformity. There's severe lack of extension of the DIP joint. The patient has complete active flexion, but is unable to extend the PIP joint. Now, a pseudoboutonniere deformity can become a true boutonniere when the central tendon attenuates, and that's likely to occur when the severe flexion contracture of the PIP joint, as in this patient who had a hyperextension injury to the PIP joint and tore the volar plate, and it scarred down in this position. So a pseudoboutonniere deformity can turn into a boutonniere deformity. In subacute boutonnieres, which occur about 7 to 10 days post-injury, there's usually swelling of the joint, a loss of active extension, and passive PIP extension can also be restricted. Use an extension splint for 5 or 6 weeks. Start them on exercising immediately for the DIP joint. And this patient did well, regained full PIP and DIP flexion, but had a slight loss of PIP extension, which wasn't severe enough to warrant surgery. When passive PIP extension is restricted, you could use serial casts that are changed weekly, similarly to what you would do with a child with a club foot. And this patient had a total of 6 serial casts and then had therapy and got a very good return of motion with only a slight deficit in PIP extension. A chronic boutonniere deformity, the indications for surgery are you need supple, soft tissues, excellent passive mobility, and critically important, you need a cooperative patient. There are numerous surgical techniques that have been published, and they all involve relocating the lateral bands dorsal to the axis of motion of the PIP joint. I'm a firm believer in operations to keep it simple. Use a curved incision over the PIP joint, better than a bayonet incision, because generally you don't want to make incisions where tendons will glide. And the apex of the incision is at the mid-axial point on either side of the joint. You want to bring the lateral bands dorsal to the axis of motion. You want to suture them together, reforming the triangular ligament using 1 or 2 5/0 or 6/0 nylons. And if possible, bring the central slip distal to the PIP joint. It's very important not to put sutures proximal to the PIP joint, because if you do that, you'll wind up with a very firm repair and the patient will never flex that PIP joint. A chronic stiff boutonniere deformity is one of the most difficult problems in hand surgery. It's actually 2 problems. It begins with the incompetent extensor mechanism, and then you have secondary PIP and DIP joint and a contracture of the oblique retinacular ligament. Do not try to reconstruct the extensor tendon when PIP and DIP joints are stiff. Doing capsulectomies and an extensor tendon reconstruction at the same operation will change a stiff flex finger into a stiff extended finger. The first objective is to try to treat the PIP and DIP joints non-operatively. Try to reduce the problem to just the extensor tendon injury using non-operative methods for the joint contractures. Dynamic splints are generally not effective because there's an insufficient extension force. Static progressive extension splints exert more force, but usually not sufficient to result in any improvement. And serial casts exert even greater force, and they can be effective if the joint stiffness is not rigid. When non-operative measures fail to restore passive joint motions, surgery can be considered, but it requires a 2-stage procedure. You have to do capsulectomies of the PIP and DIP joints. You got to release the oblique retinacular ligament, And then stage 2 is reconstruct the central tendon. This requires an incredibly well-motivated patient who will exercise effectively to regain active flexion after stage 1, and also to maintain passive PIP and DIP joints prior to stage 2. And usually both flexion and extension dynamic and static progressive splints are required. 2-stage reconstructions are rarely indicated and rarely successful. I've done it only twice in my career with not the greatest results, because the interval between stage 1 and stage 2 is easily 6 months or more, and the overall recovery is generally more than a year. Alternative procedure to a 2-stage reconstruction is a PIP fusion. Thank you very much. I'd like to now introduce our next speaker, Dr. Kim, who's going to talk about flexor tendon injuries.
Thank you very much. Let me share the screen. And I thank Dr. Gilbert for having me follow Dr. Posner after that talk. I don't know if you guys know, but that talk is a very famous talk that he gives almost every one of these meetings. Can always learn something from it every year. Let me see. Do you guys see my slides?
Yes.
And you guys hear me? Okay, great. So hi, everybody. Thank you very much for having me. I was asked to do a presentation on flexor tendon injuries. This is a well-discussed and well-studied topic due to the fact that it's a high-yield question on self-assessment and OITE. But as you know, the ability to perform a flexor tendon repair is one of the things that distinguishes a hand surgeon from other subspecialties. But I want to take a little bit different approach as opposed to coming from a student's perspective. I wanted to see the surgeon's perspective on this. And you know, I want to see what I want you guys to see what I see in the operating room, and for residents and fellows, you can kind of learn from that. And then the attendings that are more senior than I am, you can kind of see what the junior guy is doing and maybe help me out to become a better surgeon at repairing these. So let's just get straight to the point. So this is a 25-year-old female with a knife cut to the metal ring and small finger, complete loss of tenodesis effect, and both FDS and FDP are out. This is an acute injury, and we're all surgeons and we can make this better, so we're going to operate. Okay. And this is a good time to go into zone of injury. Let me just minimize this. Okay, great. So the zone 1 is distal to the FDS insertion, and this is the flexor tendon that has a separate classification for FDP injuries, called the Leddy-Packer classification. It goes from 1 to 5. It's the type is a little bit weird. Type 1 is actually worse than type 2 and 3. And then type 4 and type 5 are also very difficult to fix. Basically, type 1 is when it retracts to the palm. And that's the one that you have to repair very quickly, where it ruptures from all the vascular channels and goes through all the pulley sheath. Whereas type 2 and 3 are the ones that get stuck either at the A4 pulley or at the level of the PIP joint, because it has a bone fragment attached to it. The zone 2 is what we're all familiar with, right? It goes from the proximal A1 to FDS insertion. And this is what's known as the no man's land, because it's prone to adhesions and re-ruptures. And in the old days, they never used to fix these. For the residents and fellows, please note that your A1 pulley is not at the digital palmar crease. It's actually at the level of the palm, over your digital palmar crease. So it's much more proximal than you think. Zone 3 is distal transverse carpal ligament to proximal A1. This is where the lumbricals are. And if you read papers and textbooks and they say, hey, there's less scarring here, there's no sheath, it's an easier repair. but I'm gonna kind of go through that with you. And then zone 4, as you know, it's carpal tunnel. You have to worry about the median nerve. And then zone 5 is typically what we consider the spaghetti wrist with a suicide attempts. So zone 3, I just want to quickly go over. As you can see, this is a zone 3 injury, which in my opinion is not easy. Here's why. It's at the level of the palmar region, which we don't typically operate very often. And it houses the branching common digital nerves of the median and ulnar nerve. And it also has a superficial arch of the radial and ulnar arteries. These neurovascular structures are superficial to the tendon. So you have to dissect them out to get to where you need to go to repair these. So I think in my opinion, these are actually very difficult injuries to fix. And they do scar. I mean, you can see this big bulk of scar here on the palm. So you can get significant amount of stiffness and adhesions. And when they move the finger, you can actually see the skin move with it. So this particular patient was very compliant and did well, but it's not as easy as they make it sound. So so let's go back to the first patient. This is the zone 2 injury involving the 3 fingers. And this is after the repair. This is the intra-op assessment of the tendon excursion and repair integrity. Notice that there's no knot or suture impinging against the tendon sheath, and there's no gapping at the repair site, which is associated with higher failure rate. For residents and fellows, there are a lot of things you can learn from going into the OR. So pay attention to sort of everything you see here, okay? And this is just me moving the fingers back and forth after the repair. This is the still image of the same video, okay? Let's go through what I see, okay? The cut, knife cut, was at the level of the digital palmar crease, which is what typically happens with a cooking injury. The first arrow is where the cut was. The second arrow is where the tendon is actually cut. Why is the tendon so much more distal than the site of trauma? Think about that for a second. If you want to be super slick, then you can estimate where the tendon cut is and minimize the length of the incision, hence less scarring. In some cases, you don't have to reopen the healed site to identify the both ends of the tendon. When you're designing your incision, though, you have to make sure that you can incorporate the injured site if needed, if you're not reopening the cut site. This is what the junior residents see, right? I mean, when they prepare for a case, they look through and they worry about all these various type of core stitch, and they also think about epitendinous stitch, which are both important. And then they will go read about all sorts of cool repair techniques and then fundamentally understand that the number of core sutures traversing the cut site makes a difference in the strength of the repair. An excellent article by our NYU colleagues summarized these repairs for you in their yellow journal in 2018. The techniques are various techniques. There's Bonell techniques, Casper grasping techniques, Kessler Tajima technique, and my personal favorite is the cruciate repair. But they're all some sort of variation of 2 to 6 strand techniques. So these are some of the concepts that have been kind of beaten down to us, right? You have the number of suture strands crossing the site, suture material, incorporating the locking configuration, and then you add the epitendinous suture, which improves the strength by about 10 to 50%. But I want to focus on 2 additional concepts here, okay? That's perhaps less emphasized. The effect of the tension with a effective tension causes a shortening of the tendon and then a little clumping when you repair these. And when you clump these by 10 to 20%, the amount of force that's required to gap the tendon when you start the range of motion goes up by about 100%. So you have to shorten it just enough to increase the strength of the repair, but not too much so that it actually causes an impingement of the sheath. When I used to do these flexor tendon repairs when I was first starting out, I clumped them and I never had any re-ruptures. And then I thought I was getting really good. And then I started making them without any clumping and made it like perfectly straight. You could barely see the repair site. You could barely see the sutures. And I actually ended up starting to get ruptures of my flexor tendons. So then I went back to clumping, and then I went back to clumping, and the ruptures have not happened again. So this is one of those things, one of the biggest advantages of Wallon procedure is that you can actually see the gapping as they actively flex the fingers. I also want to briefly mention, that's perhaps less emphasized in this paper, is that, and I think it's equally important, is that all mechanism of failure happens at the knot. And I emphasize this to the residents. And most of them still ignore me anyway, but your knot has to be cinched down. You can put 7 or 8 knots there, but if it's loose knots, they will unwind over time, and that's the site of failure. And it is the weakest point of your repair. So don't blame the patient, don't blame the tendon. It's not the suture material. It's your knot that's actually causing it to rupture. So let's go back to the our repair here, as you can see. So we talked about the locking cruciate and epitendinous stitch. The slight clumping of the tendon, which helps with the strength of the repair and prevents that 2 millimeter gapping, which is known to cause higher failure rate. We also got to talk about the purchase length of the tendon, which one side here, I think it's about 1 centimeter. This side is probably about half of that. But you really want to grab that healthy tendon away from the repair site. Based on this particular study, if you repair with the grab of about 4 millimeters, it diminishes the repair by about 50%. Sometimes it's somewhat limited by the curvature of your needle, but with practice, you can definitely grab it farther away from the cut site, which I think helps dramatically with your strength of the repair. And then when you're thinking about where to place the knot, you want to go away from the pulley sheath, whether it's distal or proximal. As you move the finger, you have to kind of estimate where it's going to get caught, and you want that knot away from that particular pulley. So these are all the additional things that you have to think about repairing these. So this is the repair of that last patient with a metal ring and small finger zone 2 injury. It's okay. I mean, she's got good extension and good flexion, but as you can see, she lacks a little bit of DIP flexion. And she's a recreational pianist. So this is her demonstrating sort of the independent motion of each finger. So pretty good, but I think we could probably do a little bit better job with this. So let's go to, here's the second example, similar zone 2 injury. I think we consider most things here. We have a 6-core stitch, locking cruciate with the horizontal mattress with the 405er wire. Tendon purchase is about centimeters away from the repair site, as you can see on both tendons. We have epitendinous suture with a usually 5.0 or 6.0 Prolene or PDS. And I was mindful of where the knot was placed away from the proximal pulley in this case, because I didn't want to get tethered. And of course, you flex and extend, make sure there's no gapping at the repair site. Okay. And this is that same patient. And here's our outcome. I think in her case, there's a little bit better DIP flexion and good extension. So we talked about a lot of things. So what did we not talk about so far? These are the images from the prior two cases. What's missing here? I'll give you a few seconds to kind of figure this out. What's missing? Right? Pulleys, they're missing pulleys, right? Where are the pulleys? All you see is naked tendons. And so the question is, how much pulley do you need to maintain good flexion? And there are many, many variations of biomechanical studies. It's difficult to keep track of them all. How much pulley is truly needed? Furthermore, the methods of all the studies are very different. So it's really impossible to compare the two and understand what is actually clinically relevant. This is a small case series of 7 patients. The authors concede that it's a very small number of patients. However, a lot of reviewers commended this paper on the detailed documentation of how much was cut and how well that they documented the post-operative evaluation. And they released the entire A2 pulley, right? A2 pulley is the most important pulley that we talk about. And the results of releasing them all after a tendon repair, the patients actually ended up getting mostly good to excellent outcome. There were 2 tenolysis that was performed, and that's a little bit higher than what's traditionally thought for these acute repairs. But nonetheless, most of the patients ended up having good outcome here. Let's consider this example, right? This is a brand new patient. FDP has been already repaired, as you can see here distally. Which pulley do you think are vented here? And I'll give you a few seconds to kind of think about that. In this example, I think most of A3, C2, A4, C3, and C5 are vented. Okay. Also, the word vented just means we cut it out. And the intact pulleys here are A1, A2, and C1. For the junior residents, this will be a nice time to review the pulley order, right? You have the A1, A2, C1, and then you have A3, C2, A4, C3, and A5. Remember, don't trust everything you read. Pulleys are important, but you can cut them and still be okay. And by the way, this is the figure from Netter's anatomy. I always like to point this out, but as you can see, it has an incorrect information. And if for those of you guys who have the book, you guys should open this case and figure out what's kind of wrong with this picture. So this study investigated biomechanics of FDP tendon in a cadaver. So we talked about A2 pulley, potentially okay to release. And then now we're going to talk about the A4 pulley, right? They cut the tendon, they repaired it. And then they sequentially cut, either half of A4, all of A4, and then A4 plus additional sheath. And they found that the work of flexion compared to a baseline condition changed about 3% by releasing the A4 pulley. So not much. In fact, intact pulley actually had increased work of flexion due to the bulkiness of the repair. And if you look at the numbers in biomechanical studies, A4 pulley release does very little to the overall excursion length, change in peak force, or changing energy. So in normal sort of setting, you have the FDP, which generates about 45 newtons of peak force. Tendon excursion is about 3 centimeters, and then the muscle generates about 1.3 joule of energy. Once you release the pulley completely, changing peak force is about 1 to 2 newtons out of 45 newtons, so very minimal. Changing excursion is about 1 to 2 millimeters, which is also minimal compared to 3 centimeters. And then the amount of energy to flex that finger changes by about 2 to 18 millijoules. Again, once again, pretty negligible compared to based on a normal condition. So this is that same patient where I showed you where we cut the pulley, and this is range of motion. So this is the one that I vented all the pulleys, and the outcome is actually pretty good. He's got a good DIP flexion, and you know, for me, this is an excellent outcome. In 2014, they had this flexor tendon injury committee, and it's kind of a paper where it's like a more interview and response, where the experts kind of gather together and they kind of tell them what they do. And almost everybody, except for one, and I won't say who, but except for one, everybody is very comfortable releasing up to 2/3 of both A2 and A4 pulley, or all of A4 pulley if necessary. And none of them actually went back and repaired the pulleys after the tendon repair. So for me, after all that, my rule is vent the pulley when you have to and don't vent when you don't. So when it gets into the knot and it gets in the way of the good repair, or impinges on the against the flexor sheath, then I have no problem cutting them out to get good excursion of the tendon and get a good repair of the flexor tendon. I want to just briefly talk about zone 1 injury, because I think this is personally very difficult for me. Trying to get bone tendon interface to heal, I think it's challenging. The pull-out suture with external button is one of the most popular ones. And in many many places in US still prefer this. I prefer the pull-out suture with the bone tunnel technique. It doesn't require buttons, but you do get knots and you can get nail plate deformity. And it's kind of funny that this is the letter that European fellows who were training in United States wrote to Journal of Hand Surgery, the European version of it, kind of making fun of United States for still using buttons to repair these. And they prefer this sort of transverse interosseous loop technique, or also known as tilt. It's basically you put a 21 gauge wire, and then you put a suture through it and you weave the tendon repair. And therefore you don't have to go through the dorsal side of the finger. And basically our friends from Rochester kind of compare all the techniques, including suture anchors, and found that that there's really no difference in the ultimate load and work to failure in all techniques. So I haven't personally done that technique, but I'm certainly interested in doing it. I'm going to stop there. I was going to talk about two-stage reconstruction, but I think I'm out of time.
Thank you, Dr. Kim. Can you, so we do not have any questions left. The questions that were posed were answered. So I think what we're going to do is we're going to go to the break, which goes until 11:40, and then we'll start with Dr. Polich at 11:40. So I'm just going to put up during the break some information about our sponsors. You could take a look at that on a little slideshow. And I just want to thank all the morning speakers. Those were really outstanding lectures. And I think all of us, from residents and fellows to people who have been in practice for 20, 30 years, learned something. So thank you. I apologize. So there are some questions that just did come up. So I'm going to read them. Hopefully our panelists are still there. We have a question for Dr. Kim. In zone 2 flexor tendons injuries, do you repair both the FDS and FDP tendon or only the FDP tendon?
A great question. If the sometimes the FDS, if it's distal where it attaches, it's pretty flat and pretty flimsy. So it's hard to get a good grasp, but I do try to repair them, but I don't do like this whole 4-core or 6-core stitch. Maybe generally like a figure of 8, whatever kind of accepted. And I do try that. I typically do 1 slip only. If the quality is not very good and you don't think they can get a repair, then I have no problem not repairing them. I've had once where I had, I talked about my re-ruptures in the past. I had a guy who re-ruptured his FDP, but somehow managed to keep his FDS intact. And he was actually happy with the function of his FDS finger. So that kind of saved me. So I do, if the conditions are right, I do repair them, but it's case by case decision.
Okay, another question for Dr. Kim. Do most surgeons do Walland for flexor tendon repairs? Walland, for those who don't know, is wide awake local anesthesia, no tourniquet.
No, I don't do well on that. So, but I think it is one of the huge benefits is that you can see the active flexion. So what I do is because I prefer my patients not talking to me. I fix them and then I aggressively move them. I mean, I test out that repair to make sure that there's no gapping and there's no impingement of the knot at the sheath. And I really do a very careful intraoperative assessment with the passive motion. And for, until now, at least it's been I think the outcome has been satisfactory.
I'll just answer that for myself. It really depends upon what you're repairing. And obviously if you have multiple nerves and a vessel, but for most flexor tendons now, if you think the patient could tolerate it, I do them under Walland with a little sedation. That way you can see actively whether anything impinges and the gapping. Certainly you can evaluate that better with them actively pulling, but you have to have the right patient, obviously. So another question, I assume for Dr. Kim, what are your thoughts on loop suture?
What do you mean like loop sutures? You mean like a super mid? I guess is what they're talking about. So I'm going to assume that's the case.
So, yeah.
Yeah. So super mid, yeah, I love them. So I use 4 fiber wire. Loop sutures are totally fine to use. And I think they're designed for flexor tendon repair. I think I don't think the suture material actually matters more so than not any more than your technique. So I personally like cruciate repair, but I lock each throw at the edge. So that it's a completely locking construct. So then the question comes, well, then how do you sort of get that nice little clumping to prevent gapping? I actually do a horizontal mattress first. So I do a horizontal mattress, and then and you have a very good control of how much tension you put onto that repair. And once you like that, just the subtle clump of that flexor tendon, and you're happy with it, then I proceed with a locking cruciate repair, which is a 4-core stitch. So now you have a 6-core stitch, and that cruciate repair is almost think of it like a bridge plate or a neutralizing plate. Is just to hold a tendon at that perfect length that you've created with the horizontal mattress. And that locking construct is very, very strong. I mean, you cannot rep that out. And that's generally how I do it. But you can do that core stitch with a super mid loop sutures, and I think that's totally fine.
Dr. Kim is very popular. So we have another question for you. How many knots are you throwing on your flexor tendon repairs?
Usually around, well, 7 is my lucky number, so I use 7. but each knot, I cannot stress this enough, has to be cinched down. You think it's cinched and it's not cinched. And I think that's the biggest problem with these repairs re-rupturing. So if like the example that I showed you, you have the 3-finger repair. When you have multiple finger flexor tendon repair, and then let's say you do the small finger first, and then you go to the ring finger and you go to the middle finger, just look back at the small finger repair. I'm telling you, your knot is already starting to be undone. So you have to really take that time to cinch that knot down.
Yeah, and I agree. Although I think that it's certainly a balance between doing enough knots, and you obviously don't want your knot to impinge, or be bulky. But I think at the minimum 4 knots. And another question for Dr. Kim. It's interesting that when there's no clumping, you had more re-ruptures. Did you notice that the re-ruptures at any site at any specific time period, for example, at 2 weeks when the tendon is the weakest?
Yeah, it's usually within 2 to 4 weeks. I have ruptures that come after. So I generally start therapy whenever I see them back on a first post-op visit, which let's say is about 10 to 15 days. I've gotten a little bit more aggressive, but at that time when I was doing it, it was about 10 to 15 days. It looked good flexion. And then we start the therapy and they come back in another 2 weeks to make sure that the tendon is intact. And that's when I see it rupture. So yeah. So guys, you have to clump the tendon a little bit. Don't try to make it look perfect, which is what I did. And then I started to get little gapping. And then I think that's why it ruptured.
So for everybody who's still on, I'm going to pose this to Dr. Kim. Just can you briefly discuss your post-operative protocol, whether you're using early active motion?
I do. I pretty much give the therapist free rein on what they want to do. And I actually, when I speak with the therapist, I tell them, hey, listen, if this tendon ruptures, it's not your fault, it's mine. And so then they can get aggressive with them. Only like if the tendon is kind of frayed and I'm very, very worried that this may rupture just because the quality of the tendon is so poor during the repair, then I will personally call the therapist and say, hey, I'm a little bit worried about this. It's not my usual flexor tendon, just go a little bit more gentle on it. And so I do communicate that to the therapist personally. But I do now, I see them back, it depends on your office hour schedule, but I see them back within a week or at week. And then I give them a extension blocking splint, and then I have them start the active flexor protocol. And the therapists are kind of do what they are trained to do, but I do allow them to actively flex the fingers down all the way to the palm if they can. So I give them very little restrictions other than weight bearing, and then sudden passive extension. I try to avoid.
So Dr. Kim, there's been actually several requests for the 2-stage reconstruction lecture. And, since a lot of people are on break and are not here, I don't want to put you on the spot, but would you be kind enough to record that portion of your lecture, and then we'll upload it to the website along with the other pre-recorded lectures?
Oh, that's no problem at all. We're actually making a video on it. So we'll just post that once it's finished.
Thank you.
Even though this is break, I think if who's ever on, I have a question for Dr. Nellens. Could you just go over your exact protocol and follow up for your mallet injuries, meaning simple soft tissue mallets that you're splinting?
Yeah, so like Dr. Posner said, I prefer the dorsal splint. When I see them, so long as they're within the first 6 weeks, I typically will splint them and kind of treat it like new. After about 6 weeks, I feel like it's not really going to be that helpful. So I placed the dorsal splint. I actually have a handout made for them to show how to change it at home. I asked them to change it at 2 weeks. I see them at 4 weeks. They change it again 2 weeks later, and I see them at 8 weeks. And then we switch to nighttime splinting only for another 4 weeks. So I tell them this is a 3-month kind of ordeal. And I would tell you, dorsal splinting lets most people type, and they're pretty functional. It's annoying for showers and having to wash hands. So I think my one kind of exception for the splinting is for healthcare workers or my orthopedic trauma partner who gave himself a mallet finger. I'll put a 6'2" longitudinal K wire in and leave that for 8 weeks.
I assume you cut the pin beneath the skin for those, correct?
Yeah, I just get the big bolt cutters, and it seems to work pretty well. The skin, if you kind of push it back, cut it, and then pull it back up, and I put a stitch over top of it to kind of encourage the skin to heal. It seems to be pretty well tolerated. So I've done that for dentists and nurses, and again, some surgeons.
6 weeks versus 8 weeks. Any thoughts from the panel?
I go 8. It's just my preference. I feel like at 6, they're still tender there. Maybe some kids, like if it's just not how I see them back. So I usually don't see them at that 6-week mark, whether they self-DC their splint and start kind of using a little bit. I don't know. But I just feel like they're still tender usually at 6. So I keep it till 8 until they're non-tender. That's my clinical kind of judgment.
For me personally, I think a lot of it depends on how the mechanism of injury happened. If it's truly a bony mallet, and I'm not concerned that there is also a tendon stretch injury, then I'll often treat it like a fracture. So 6 weeks of splinting and then start getting them moving. The other thing I do want to mention is over the years, I've changed from dorsal splinting to actually giving the patients 3 different splints. I give them a stack splint, I give them a dorsal splint and a volar splint, and show them how to change the splints, because I've had a lot of patients with a lot of sensitivity on that dorsal skin. And if they're not going to wear their splint because it's painful, then I would prefer that they alternate throughout the day, or even multiple times throughout the day with different types of splints. So yes, I do like the dorsal splint because it's the most functional, but then I give their skin bridge a little bit of a break so they're not under constant pressure.
Yeah, my 2 cents worth are when I follow these patients fairly often, at least have them come back at 1 or 2 weeks, because I find that many of these patients end up not putting their splint on in the correct position, and the finger is flexed down. And if you have them stay like that for 4 to 6 weeks, it's doing nothing. The other thing is it really depends upon the fingers. So if you have a woman with a little finger mallet injury, you know those patients are not going to do well no matter what. They're going to end up with some loss of extension. So you definitely just want to set expectations for these injuries.
So there's a question from the audience. How do you treat a soft tissue mallet that presents after 6 weeks?
Maybe Dr. Posner can answer that, if he's still on. Not maybe Dr. Nellens.
Yeah, I mean, I think you can have a talk with them about how on it, like if they are okay with the deformity. I mean, some 65-year-old people with some pre-existing arthritis seem to be okay with a little bit of a bend in their finger. Some kind of younger patients may not be. I think I explained what a dermatotenodesis might look like. And it's doable. I think I'm pretty aggressive with the amount of tissue I take away, and I actually pin them in hyperextension for about 6 weeks. So if they're willing to have a pin sticking out of their finger, and I suppose I could bury it just like I do for a kind of just a regular one, soft tissue in healthcare workers. But but if they're willing to undergo that, I think I offer it for the chronic mouths.
Okay, so I think the questions are done and we have about 5 minutes and then we'll restart with Dr. Polich. Thank you, everybody.
Thanks, Rich.
You guys able to hear me? I know we're not starting for another minute. Just want to make sure we're all set.
Yep.
We can hear you. And you can see my slide deck,
Yep.
although I don't think we call that anymore. Slide deck.
You can see your intro slide.
Thank you. How you doing, Larry?
I had an
How are you?
intro slide to go before you, but that's okay.
Feel free to jump in.
No, because you have to then unshare, but then reshare again. It's fine. I'll just introduce you in a minute. We're at
All right.
10:39. Okay, 10:40 a.m. Welcome back, everyone, again. Thank you again to our sponsors for supplementing our ability to offer this course free for everyone online and pre-recorded lectures. And we'll go straight to the next lecture. The esteemed Dr. Polich, our former president, who will be discussing fingertip injuries.
Thank you, Renata. My name is Dan Polich. I'm the co-director of the New York Hand and Wrist Center of Lenox Hill, and I'm going to be talking today about fingertip injuries. I have no relevant disclosures, except that I will be on time so I don't miss that much of the Michigan-Indiana football game. Except it's not advanced. There we go. Hang on 1 sec. There we go. So fingertip injuries are the one of the most common injuries of the hand, typically in older children and young adults, men much more than women, with the middle finger most commonly affected. Over 30,000 injuries per year seen in the emergency room, with half of these involving a finger fracture. The anatomy of the perineum is very highly specialized. It's a highly specialized structure which contributes to precision function of the hand through tactile feedback and fine motor control. The skin has abundant fibrofatty tissue that's stabilized by multiple fibrous septa. So if you look on the illustration on the bottom, you see the septa that go from the dermis to the periosteum. These are the septa that you need to divide when you're INDing a felon, which Renata will talk about on the next presentation, but they don't allow for mobilization of the skin too easily. It's got very thick epidermis and it's glabrous skin. The anatomy is a little bit unique. If you look up at the upper illustration, these are some of the terms that we use to describe the structures. The hyponychium is the tissue at the distal aspect of the fingertip, just below the nail plate. The sterile matrix is the tissue responsible for the nail plate's adherence to the nail bed. The germinal matrix is responsible for the nail plate's growth and where the nail comes from. The eponychial fold is the skin tissue that comes out distally over the dorsum of the fingertip that rests on the proximal aspect of the nail plate. The lunula is the moon-shaped white structure at the base of the nail plate. And again, if you look closely, you can see where how much fibrofatty tissue there is. If you look at the end of the, look how much tissue on this illustration is there before the end of the finger. There's plenty of padding, which is important. The goals of treatment are to have a painless fingertip, durable, sensate skin. You want a well-padded fingertip. You want to maintain length whenever possible, in particular on the thumb. You want to preserve the nail bed and the nail plate, and ideally early range of motion and a good cosmetic result is ideal. When you initially see these patients in the emergency room or in your office, you want to get a very good evaluation. So you got to control the bleeding, and often one of these commercial digital tourniquets can be utilized, or a Penrose drain. Sometimes you have to administer a digital block or wrist block so you can adequately assess and wash it out and assess what structures are exposed or damaged. And you want to think about several things when you're looking at these patients. Is there loss of tissue, in particular the pulp space? Is there exposed bone? Is there a fracture? Always get an X-ray. What's the status of the nail bed? What's the level and angle of the amputation? And then the thumb has certain factors that are most important to treat. And then what about the patient-specific factors, their age, any comorbidities, what's their work status? Do they need to get back to work right away? Things like this. And probably the most important, which I talk about it every time I'm in the OR with the residents, is to remove the tourniquet at the end of your evaluation. This is from 2019, a teenager cricket player who had a thumb distal phalanx injury under a long-lasting digital block, went home that weekend complaining of pain, called, they gave pain medicine, said come in on Monday, and when she came in, she had a dead finger. So that should never happen. Always, always, always remove the tourniquet. The classic classification for fingertip injuries by Rosenthal describes it whether there is exposed bone. Zone 1, no exposed bone. Zone 2, there is exposed bone, but there's enough distal phalanx that you could preserve length and you wouldn't have a hook nail. Zone 3, it's at the level of the lunula or more proximal. And in general, those more typical of doing a shortening or revision amputation. And then we have a descriptive classification. The descriptive classification is just where the soft tissue loss is. So on the top illustration, that's a dorsal oblique amputation with more dorsal loss than volar loss. The bottom one is a volar oblique amputation. And you can have a combination, volar, ulnar oblique, and it's very good for describing these over the phone or to whoever's on call. So if there's no exposed bone, obviously you can just suture the wound if it's something that's suturable, but often there's not a lot of mobile dermis, so it's very hard to advance the tissue. And I always see these patients come in where someone hogged it together with 2-0 nylon, not really the great way to do it. If there is a wound that's less than 1 centimeter by 1 centimeter, no exposed bone, you can let this heal by secondary intention. Multiple different ways to treat it with dressing changes, but in general, universally, patients have an excellent result. If it's more than 1 centimeter by 1 centimeter, you can also do it with dressing changes. It just takes longer, but also has an excellent result. Some people feel that skin grafting these or using acellular dermal matrix is better because you get prompt coverage. The grafts can be used from the hypothenar eminence, the palm, the amputated part, the wrist, and we'll see some example of that later on in the talk. The benefit of covering it is you get immediate coverage, but you do need to immobilize it to prevent shearing. People are often left with cold intolerance and diminished sensation. When there is bone exposed, the best treatment is always controversial, and it depends on who you talk to and how what their training level is. So obviously you can do a revision amputation if it's shortened. If you can try reattaching the amputated part, not a microvascular reattachment, but someone who's got bone, soft tissue, fat, skin, you can try a non-vascular composite graft. And surprisingly, a large percent of these can take, or at least partially take, and if nothing else, it can be a biologic dressing. And the typical factors that make it more likely to take are younger age, non-smokers, non-diabetics, et cetera. In terms of flap coverage, we'll get into this, but you can do local or regional flaps. Acellular dermal matrix we've been using a lot more in the last 5 to 8 years. The treatment choice is individualized, and that's not just for the patient. So the patient has specific goals, and the type of injury sort of predicates what you're going to do, but also the person treating them, depending on what their experience is and what their comfort level is. And then what about the timing of these? So 20 years ago, when we were first in practice, some people were doing this in the middle of the night. We've clearly proven that you don't need to do this in the middle of the night. Having a little bit of bone exposed, you can wash it out, put a little Zeroform on it, and see it in the clinic and put it on the next OR day. We looked at this and presented it in 2012 with 32 digits, all with exposed bone, various flaps. The average time from injury to flap coverage was 8 days. None of them got infected. So this is something that you can easily send out. So in general, if there's sufficient nail matrix that remains to provide a stable and adherent nail plate, then consider a local advancement flap. So that's the simplest and most easy one to do. If the angle of the amputation does not permit a local advancement flap, so that's a volar oblique soft tissue loss, then consider a regional flap. That's sort of the next complicated procedure. And if the amputation is more proximal, or the patient is a poor candidate or needs to get back to work very quickly, consider revision, amputation, and shortening. When you do a revision amputation, you want to make sure you ablate the nail bed, because that's your best chance of not getting some of the nail plate growing out for the patient's duration of their life. It's hard to remove when they come in late, when the anatomy has been operated on several times. You want to shorten and bury the digital nerves so they don't get a neuroma. If there's abundant skin, you'd like to advance the volar skin over the tip of the finger because that's glabrous and it has more padding than the dorsal skin, and never advance the profundus over the bone because you can end up with a quadriga effect. When I was in high school, Ronnie Lott was a super well-known receiver for the 49ers, and he had an amputation of his small finger, and they said, we can reattach it, but you'll be out for the remainder of the season, or we can throw it in the bucket and you can get back there and play. And obviously that's what he did. Now let's talk about local flaps. So these are ideal when you can perform them. They preserve length. Skin grafting is not necessary. It's similar tissue that you're covering the defect with. And typically you can end up with normal sensory end organs. So you have normal sensation. And the classic one is the Addusoy, which is a volar advancement flap. The Cutler, less commonly used, which is a lateral. And the Moberg, which is for the thumb. If we look at the illustration on the left, that's the Addusoy. It's a triangular shaped flap based at the DIP flexion crease. You want to divide those fibrous septa that we spoke about in the second or third slide. And you're basically hinging this on the neurovascular bundles radially and underly, and you can advance it, sew it to the nail plate or nail bed, and convert the V to a Y. Here's a clinical example of a transverse amputation with exposed bone, V converted to Y, and here's the clinical result, which is quite good. If you can't do a local advancement flap, now you have to start thinking about regional flaps. So these are derived from tissue not immediately adjacent to the defect or the amputation part. These are primarily for volar oblique amputations. These are ideal because they preserve length. However, they do often require 2 stages. And so older patients, you get worried about stiffness, and they're in general a insensate graft, but yet for some reason, people do get pretty good sensation for them. The cross finger flap is a random pattern flap based over the dorsal aspect of the middle phalanx of an adjacent digit. You can skin graft the donor side or use the dermal matrix. And this works quite well. However, often there is a color mismatch, in particular with patients with dark skin. So here's an example of someone with a volar oblique amputation of the middle finger. A cross finger flap was placed with skin grafting over the donor site. The skin was taken from the dorsal aspect of the index finger. And here, the patient has an excellent functional result, but you can see cosmetically the discoloration in the skin, which is typical of the cross finger flap. The reverse cross finger flap is similar, typically was used for dorsal exposure of tendon or bone, where you would sort of open book the skin and then secondly, open book the subcutaneous tissue and then skin graft it, but this has largely been replaced with the acellular dermal matrix. You don't need to do that anymore. The Diener flap I love. It's a random pattern flap. You got to be careful of the radial digital nerve. Much more difficult to do this on the ring and the small finger. Again, you have to worry about PIP joint stiffness. There's generally not a donor defect because most of us do this H flap, which you can see illustrated on the right. When you divide it, you can advance the proximal flap distally and the distal flap proximally to cover the donor site. My former partner, Charlie Malone, wrote the sort of quintessential paper on 150 patients that had this. The 3 guiding principles were designing the flap near the MP flexion crease of the thumb, fully flex the MP and the DIP joint of the affected finger so you minimize maximum flexion of the PIP joint during the immobilization period, and then divide at about 2 weeks. And surprisingly, had an excellent clinical result. And actually, their sensation in that study was 7 millimeters, which has been actually proven by one of our studies, in addition to multiple other additional studies, which doesn't make a lot of sense how they get such good 2-point, but they do. Here's an example, of a transverse amputation with exposed bone. This is prior to dividing the graft 2 weeks later. Here's the patient at around 5 or 6 weeks with an excellent cosmetic result with minimal stiffness. On the donor side, you can see the H graft at the base of the thumb. About 6 years ago, this young woman came into my office with 2 volar oblique amputations with exposed bone. And so this requires a little bit of talk to the patient, see what's best for her. Do you do 1 Diener flap, 1 cross finger flap, 2 cross finger flaps? I decided to do a double Diener flap. Had never heard of doing one of these, but I know how vascular they are. The skin, I wasn't really worried about the skin not surviving. This is prior to division. I actually had to take some skin from the palm to skin graft proximal to the middle finger because there was more tissue loss there. And here she is at a year with an outstanding clinical result, which we published in 2017 Journal Hand Surgery. The next sort of complicated flap is a reverse homodigital island flap. I don't really do these. This is based on the fact that digits have built-in arterial redundancy. The flap is derived by dividing the proper digital artery proximally. You leave the nerve alone. It pivots around the transverse arch. And the boards and the in-training and self-assessments love asking what the most common complication of this is. And it's a flap loss because you're pivoting the flap, the pivot point about 180 degrees. Here's a flap being mobilized before it's rotated in. And here's an example now, or an old example of one being rotated into place. Most people now would do acellular dermal matrix for this. Let's talk about the thumb. Similar principles, but even more important to preserve length and sensibility. Small tissue loss can be treated similar to the other digits with local advancement flaps, dressing changes, skin grafting. However, the thumb has a unique dorsal skin arterial supply, which allows us to do this Moberg flap. So the dorsal skin is provided by its own blood supply. However, in the index through little finger, the dorsal skin gets its blood supply from the proper digital artery. So if you were to do these bilateral mid-axial incisions, you could necrose the dorsal skin. So you can't do this in those digits. Basically, you advance the flap with the neurovascular pedicles. You can advance it about 2.5 centimeters by flexing the IP joint. You can even make a cutback at the volar aspect of the NP flexion crease. And this is ideal because it's a thumb, you need sensation, and this is sensate skin. Here's one from a few years ago, amputated transverse thumb with exposed bone. This is after flexing the IP joint. This was a little bit of an older woman. Here she is at 9 weeks, excellent cosmetic result, had a little bit of IP arthritis, which required a fair amount of therapy to get back, close to full extension of her IP joint. If the wound is bigger than that, and you don't think you can cover it with a Moberg, you can do a first dorsal metacarpal artery island flap. This is a pedicle flap based on the dorsal radial artery branch and one of the radial sensory nerve branches. Again, you can skin graft or dermal matrix the donor site, and it works quite well, but it does require cortical reintegration. So not as good for older patients because it's their sensation is they do get sensation, but it's not the same. And finally, for the thumb and neurovascular island pedicle flap, similar, it's based on the ulnar neurovascular bundle, the artery and the nerve to either the middle or the ring finger. And you can tunnel it either under the sort of thenar area or make an incision. Here's an example of one harvested from the ulnar aspect of the middle finger, sewn in place, and the donor site skin grafted. A special 2 slides for kids with amputations. Every time I give this talk, there's always another stroller that gets recalled. This one was actually just from a month ago. 14,000 baby strollers recalled because 1 or 2 kids put their fingers in one of the locking mechanisms and had an amputation. If the child is less than 3, definitely reattach the composite amputated part. They have a very high chance of it taking because of their age. 3 to 8, you can also use composite graft or DFAT and use as a graft. Older than 8, treat it similar to an adult. And in very small kids, even a small amount of exposed bone actually do quite well. A recent study also in the last few years want us to be alert that these injuries could be a sign of abuse and neglect, especially if it's been repeated fingertip injuries in kids less than 12. So be aware of this. They found a higher incidence of this in patients with Medicaid, white race, and behavioral disorders such as ADHD, autism, depression, and aggressive behavior. So be alert for that. We discussed dermal substitutes, which have very promising results. These are glycosaminoglycan matrix with a silicone sort of bilayer on top. It was initially utilized for burn and tumor patients. It can be applied directly to exposed bone, tendon, and joint, and it basically functions as an artificial scaffolding for new dermis that grows in and new epidermis. So smaller wounds, you don't even need to skin graft, they can grow in from the side. A study not too long ago looked at 36 fingertips, all just treated with this, and patients were quite happy with no graft failures. However, the length and width was not adequately restored, which you can imagine because there's no subcutaneous fat that you are transposing, which you do with some of these local and regional flaps. People are using this for things such as syndactyly. Chuck Goldfarb is doing this with excellent results. You don't need the skin graft. Here's an example of a dorsal wound with exposed tendon and joint that in the past people would do a reverse dorsal cross finger flap. And now you can put this Integra on, peel off the silicone bilayer at 3 weeks, and it heals in quite well. Here's an example of a patient of mine who was an NFL quarterback, throwing hand, small finger, had a concerning lesion, possibly a cellular dermatofibroma versus some type of malignancy. We excised it. I put this acellular dermal matrix. You can see before I put the bolster on the third slide on the top, and then the bolster, you can see the size of the lesion. This is at 3 weeks after you take off the silicone bilayer, and then a few weeks later, it actually heals in quite well. It's benign, and he's obviously playing. And now a few questions. I think we're on time. This is a 26-year-old male with an amputated fingertip of his thumb with exposed bone. The most appropriate management at this time is definitive debridement and daily saline soaks and dressing changes. No, there's exposed bone. Cross finger flap closure, you could do that, but that doesn't have sensate skin. So there are better options such as the Moberg. Interphalangeal joint disarticulation and closure. No, you want to preserve length in the thumb. The condition on the ring finger is a result of which problem? Looks like the patient had ring and small finger partial amputation, small finger as a hook nail. Absent distal phalanx, no. Scar in the tuft, incorrect. Incomplete removal of the dermal matrix, correct. He has a remnant of the nail growing. Incomplete removal of the sterile matrix, no. That's the sterile matrix is responsible for adherence of the nail plate and loss of bony support under the nail bed. I know that produces a hook nail, which is what you see in the small finger. And then the last slide, which component of the fingernail depicted in figure 1 is the eponychium? So A is the hyponychium. B looks like they're pointing to the sterile matrix. C looks like they're pointing to the lunula. D looks like the eponychium, and E, the insertion of the terminal tendon. Thank you.
Okay, so now that Dan has logged off, I'll be logging on. Okay. And just a reminder, there will be a question and answer session at the conclusion of this second half. So there'll be an opportunity to ask questions about individual lectures in the second half at that time. Thank you. So I'm Renata Weber. I will be discussing hand infections. So first of all, short introduction. Even a small, almost misleadingly inconsequential hand injury or hand infection can lead to something pretty serious if misdiagnosed or not treated appropriately. The biggest problem with hand infections is that it causes a lot of hand swelling, which gives you then a poor outcome in terms of function and motion. Adhesions will cause loss of vital structures. And sometimes an amputation is even necessary, and a small wound can lead to a partial amputation or even a total amputation of the finger or hand, depending on how bad the infection is. Correct management is early diagnosis and correct diagnosis, early aggressive surgical or medical treatment, depending on the type of infection. Early mobilization and rehab. And in the past, there was a lot of talk about splinting. However, this is not as commonly used anymore as it was in the past. Although there may be some occasions where you do need to splint, at least temporarily. The pathophysiology of hand infections, it's usually a direct penetration of the skin, although you can have hematogenous spread in somebody who is septic and bacteria is circulating in the bloodstream, and then it seeds the skin or joints. The most common hematogenous spread I've seen is from people with previous MRSA infections, which then develop spontaneous abscesses in their soft tissue, or as mentioned before, septic joints. The local tissue becomes edematous, which then impairs the circulation, and you can get microvascular thrombosis and ischemia, and abscesses can form. The most typical bacteria is going to be your staph, and there is a lot of MRSA now in the community, which was not the case 15, 20 years ago. Streptococcus is another common bacteria, but you also have to be mindful of less common bacterias from the GI, TB, anaerobics, Pasteurella specifically from animal bites, and Eikenella from human bites. And additional unusual presentations can be from viral, fungal, and spirochetes. Pre-treatment evaluation, sometimes X-ray is always necessary. However, MRI, CT scan, ultrasound may add some additional information depending on the type of infection you have. Lab tests, CBC for sure is useful. I personally don't use the ESR and CRP that much unless I'm dealing with a chronic infection or something that's just not following a typical bacterial infection straightforward case. As mentioned before, principles of treatment are going to be early decompression if you have an abscess, warm soaks, either with betadine or with liquid soap. I personally prefer a light dressing. Make it easy. If it's a complicated dressing change, number one, the nurses won't do it. Number two, the patients won't do it. And in fact, I often tell the patients, if the nurse hasn't come back to do your dressing change in the time frame that I would like them to have it done, take it upon yourself, do it, and then have them come back and give you more supplies. Appropriate antibiotics when applicable. Not every hand infection needs antibiotics, although the majority will need antibiotics. And then again, splinting, in some occasions when you have a lot of swelling to the hand or a lot of pain, splinting may be useful. However, early mobilization and getting them into OT is probably more important than splinting. There's different types of hand infections, from a most superficial cellulitis, a skin infection, to deeper infections, and tenosynovitis specifically will be discussed later, as it's by Dr. Grossman. And I'm going to mostly focus on the first three: cellulitis, paronychia, eponychia, and felon. So cellulitis presents with redness, swelling, and pain to the skin. Usually it's very painful because the nerve endings are in the skin and your skin is inflamed. It's usually associated with a break in the skin, and patients will need either PO antibiotics, and usually when that fails, they end up back in the emergency room, in which case you admit them for IV antibiotics. And again, elevation to help with the edema and with the swelling, and warm compresses and hand soaks. So here's an example of a patient who comes in. They come to the ER because 2 days ago they were scratched by their cat. So looking at this, doesn't look that terrible, but should you admit or not? So this is cellulitis. In this case, because of the fact that it was a cat bite or cat scratch, I would admit this patient, unless they really adamantly don't want to be admitted, in which case I would have them come back in a day or two to make sure that the PO antibiotics are actually working. But because the cat, both nails and their teeth are very sharp, you can have bacteria that's pushed deeper into the skin, as opposed to a dog bite or human bite, which generally do more trauma to the skin and to the soft tissue, but leave open larger gaping wounds that don't close quickly, in which case those can sometimes be treated as outpatient, depending again on the situation. An abscess is basically a collection of pus. Depending on where it's located in the fingertip, paronychia and eponychia can be drained with a 15 blade in order to remove the purulence. When the pus is in the fingertip, as in a felon, you want to make sure that all the septa are divided, not just a superficial incision to release the pus, because you may miss half or a portion of the purulence. In deep space abscesses in the hand, especially, there's a lot of deep spaces with their own little eponyms and names. But anything that is going to be deep under the fascia is going to need surgical IND, just because it's difficult to reach and you will have an incomplete or incomplete drainage if you try to do this at the bedside or in your office. So for paronychia, usually the infection is around the cuticle, and most people develop this because they bite their nails. So you have to be cognizant of the fact that there probably is going to be skin flora in there, and treatment is IND. You may have to remove a portion of the nail. Sometimes the nail will actually begin to grow into the paronychium, and removing a portion of the nail allows not only drainage, but also prevents the ingrown nail, which can lead to subsequent or repetitive paronychias. And if untreated, this will lead or may lead to a felon. This is just an example showing how a paronychia can be drained. You can either drain it from the top or drain it between the nail and the cuticle. And again, warm soaks, IND, and when these are not treated or when there's repetitive infection, you may have to do what's called a marsupialization. I personally, in 25 years, have never done one, but we always talk about the fact that it may be necessary. And so what marsupialization is removing a portion of the paronychium while still leaving that leading edge of cuticle on the nail. You want to leave the cuticle on the nail because that helps to actually mature your nail when it goes from the germinal matrix to the sterile matrix. And then I throw this in there because sometimes you'll get a call from the ER and the story is, oh, I have a patient, 20-year-old dental hygienist, 3 days of pain and swelling to the finger. And you have to be very careful to make sure that they're not, that it is actually an infection versus a herpetic whitlow, which is a herpes simplex infection. The herpes simplex virus will get into the skin and cause vesicles. So it's very similar to your cold sores or varicella, so chickenpox, and you have that typical vesicular lesion. And these are also usually painful for about 2 to 3 days before the vessels show up. So also similar to shingles where you get vesicular lesions on the skin. These you do not want to IND because then you will spread additional vesicles to neighboring fingers or along that same finger. So these you want to treat with a antiviral like ganciclovir, fanciclovir. There's various different types on the market now, and just keeping it covered and letting it recover on its own. A felon is going to be an infection on the volar pulp of your distal fingertip. These are also excruciatingly painful because there's so many septa on the volar side of the fingertip. And it's essentially a compartment syndrome of your fingertip because of the infection. And so these you want to IND. If it's not treated, it can lead to a felon. It can lead to tenosynovitis, and it can lead to osteomyelitis of the distal fingertip. So one way to IND that is to just go through the most prominent part of your abscess. If the whole entire fingertip is pretty equally swollen, I prefer to make the incision on the non-critical surface. So for key pinch of your fingers, I try to avoid the radial side of the fingertip and make my incision on the ulnar side. But usually by the time these patients come to me, they're about to burst through the skin. So then I just make my incision directly in the dome of the mass, essentially. But if you do have a choice going either ulnar or radial of the finger, you want to go in the mid-axial plane, stay below the phalanx, and make sure that all the septa are divided. So superficial abscesses of the fingers. Anytime you have an incision, an infection on the finger, it can always extend to the volar side. This is a patient that the residents in the ER IND'd, and this is not exactly the choice of where I would make my incision. Whenever you have any infections on the volar side, even if it's not tenosynovitis just yet, but it's a superficial abscess, you still want to plan ahead. What if I need to go in to do a tendon reconstruction, where do I want to place my incisions? So then I make my incisions in the same direction as I would for a flexor tendon repair or a flexor tendon tenosynovitis debridement. Not making necessarily all the incisions, but pre-planning so that in the event I have to connect the dots, I'm not making incisions that are now going to be a problem later on when I need to go to reconstruct. So this is a patient that came in, 45-year-old male with 2 to 3 days history of worsening pain and swelling. Initially, you look at the finger, ring finger's a little swollen, you think, okay, not too bad. If they don't give you the whole entire story, it could be misleading, and you might see this picture and say, okay, the patient doesn't look that bad, give him some PO antibiotics, send him home. However, he tried to inject cocaine into a dorsal vein in his finger and he missed. And he knew right away that he missed because he said he had excruciating pain after that happened. So this particular gentleman was admitted. And after a couple of days after a day of IV antibiotics, some of the swelling went down, some of the cellulitis went down, but the finger is not looking so good. And this actually ended up progressing. I took him to the OR to debride, IND the abscess. He even had an acute osteomyelitis of the PIP joint. And then this continued to necrose further. Luckily, he still had peritoneum. So this has been, I've been treating, and he's actually still in active treatment right now. I just ended up putting some of those skin substitute products that Dr. Polich mentioned on the previous presentation. And he is slowly healing. Deep space infections. I'm going to kind of skip through this because there's a lot of information online that you can look up in order to figure out where exactly should you make your incisions and how quickly should you open up these deep space infections. But essentially the treatment is IND because your deep space, and like I mentioned before, there are several deep spaces with their own personal names. But the take home point is that if it's below the fascia, it's not going to be easy to IND. And it's also going to be difficult to IND in your office or in the at the bedside, even when the patient has a really good wrist block. So these are just easier to do in the operating room. The 3 most common spaces in the hand is the thenar, your mid palm, and peroneus, which is going to be closer to the wrist. So the thenar space, it's underneath your thenar muscles. You want to be able to get to that area without injuring any of the flexor tendons, without injuring your median nerve or the branches from the median nerve going to the thumb. For the mid-palmar space, again, the reason we need to do these, we need to decompress these in the operating room is you have better control, better visualization, and you're able to IND more effectively when the patient is sedated and comfortable. Collar button abscess, when the abscess begins on either dorsal or the volar side and then basically coalesce and become abscesses on both sides. You have to make sure that you treat both. Most common on this pinky, on the small finger, on the ulnar border, but it can happen to any of the fingers as I show on this picture. And then specifically any kind of infection that's in the small finger, if it leads to tenosynovitis, it can communicate to the thumb and vice versa. Any flexor tenovitis of the thumb can communicate to the small finger. I want to just mention briefly about human bites. One of the things that makes human bites a little bit more unique than most hand infections is the fact that, number one, you have bacteria from the mouth. And because of the position that the hand is in with the MCP flexed, any injury to the extensor tendon, even small, will cause the bacteria to enter under the extensor tendon and potentially infect the MCP joint. And so that's what makes it emergent. These are sometimes associated with a fracture, don't always have to be. And these patients need to be admitted. You can try 24 hours of IV antibiotics, but chances are you'll be taking the patient to the OR within a day or two in order to do a more aggressive and complete washout of the joint. If the joint itself is not cleaned or irrigated, it will lead to destruction of the cartilage, and they will have septic arthritis down the line. Even if they don't develop osteomyelitis, they will have basically a painful joint, which we don't want. I just throw this in here, necrotizing fasciitis. Most of these injuries happen more in the forearm rather than in the hand, although I did have one patient who the entry point was through the hypothenar eminence, and it quickly spread into her forearm, requiring multiple OR returns in order to be aggressive to cleaning out the infection. Because these spread along the fascial lines, the infection is rapid. And even in this day and age, it is still a 25% mortality rate for patients who have an infection, a necrotizing fasciitis of a limb, whether it's the upper extremity or lower extremity. And if it reaches the torso, it's still a 50% mortality. We're not talking morbidity where they have an amputation of their arm, 25% mortality from an untreated or undertreated necrotizing fasciitis. So it is extremely, extremely important to diagnose these rapidly and treat them aggressively. This is an example of a patient who had what seemed like just a cellulitis. However, the cellulitis did not respond to antibiotics. And usually on x-ray, you'll see some air within the x-ray, which then prompts the referring physician, usually the ER, to send the patient for a CT scan. But if you see air on an x-ray and there was no penetrating trauma that could explain the free air, you have to be very cognizant of the fact that it could be necrotizing fasciitis. So just some take-home points at the end. Most common organism for your hand infections are going to be gram-positive just because they're on our dermis all the time. And most of the injuries are from penetrating injuries. Pus under pressure is extremely painful. That's why felons are very painful. All pus should be drained. And the shortest distance to the pus, in my opinion, is the best way to drain it. A couple of pearls I've learned over the years. Not everything that is painful is bacterial. For example, the herpetic whitlow that we mentioned before. Masses that grow slowly and painlessly are either very bad or think mycobacterium. Even simple infections can kill you. Inexpensive antibiotics are usually adequate. You don't have to go crazy with triple different antibiotics unless someone's not responding appropriately to the initial first line defense. And I find that soap and water is truly underrated. I can't tell you how many times patients come in and tell me how they've contorted their bodies in order to not wash their hands after hand infection. After I've told them, please use soap and water, wash your hands, soak it with either liquid soap and water or betadine and water. Either way, wash it, clean it. Can't be overstated. And then one more thing that I learned from one of my ortho-oncology colleagues, biopsy what you culture and culture what you biopsy. Sometimes things look like an infection and you can get surprised, and it turns out that the patient has some kind of fungating met or a squamous cell or a basal cell or some kind of osteosarcoma that you were not anticipating. So thank you very much. And then if anybody wants to reach me, this is my email. So we're a little ahead of time, but we'll go, no, actually I'm a little bit behind time, sorry. I'm going to pass it on to Dr. Hurst, who is going to talk about Dupuytren's. So let's stop share. Take it away, Dr. Hurst.
I'm here. I'm just making sure I get this thing going properly. 1 second. Okay, can everybody see my slides?
Yes, we see them.
Okay, so I'm Larry Hurst. Now I'm professor and vice chair of hand surgery and orthopedics at Stony Brook. And I'm going to talk to you today about Dupuytren's disease. I have no disclosures. We did do work with Xiaflex, but they've gone bankrupt. The history of Dupuytren's disease is extremely interesting. Recently, Hand Surgery Resource produced this history review, which is on YouTube. And if anybody really wants to hear the exciting history of Dupuytren's and really the history of surgery, please check it out on YouTube. Dupuytren's did the first surgery in 1831 and got his name on the disease. He wasn't the first to operate on it. He certainly wasn't the first to visualize it. When we think about Dupuytren's, it's important to understand the dorsal skin is loose and pliable, and the volar skin is firmly attached because of retention ligaments. And these ligaments exist in 3 planes: longitudinal, transverse, and vertical. They are the source of Dupuytren's contractures. The cell that starts the problem is the fibrocyte, which dedifferentiates into a myofibroblast, producing abnormal amounts of collagen, aminoglycans, and fibronectin, and leading to thickening, shortening of the cord, and the deformities we see patients present with. When you study this, you start out by knowing the normal anatomy and subsequent abnormal anatomy. The normal fascial bands are Grayson's ligament, the lateral digital sheath, the natatory ligaments, the pretendinous band, and the sagittal bands. The uninvolved structures are Cleland's ligaments and the superficial transverse ligaments of Skoog. Again, here we see the normal ligaments. Note in the cross-sectional view, palmarly, we have fibrofatty tissue, which coalesces into parts of central cords. You see Grayson's ligaments, volar to the neurovascular bundle, the lateral digital sheath, which can become part of a lateral cord, and Cleland's ligaments, which usually don't involve themselves in pathological cords, but retrovascular bands do. Again, here is the example of the cords that are produced from these bands, the central cord being the most common, seen here on the right, and the nodule is noted. The spiral cord needs special attention and noting. If you look at this picture on the left, you see the clamp is holding the spiral cord, and the neurovascular bundle is going superficial to the cord, spiraling around the cord, and then going up into the finger. The result is, if you're operating on this and you approach through the skin, the first structure you're going to come to is the nerve, and therefore it is easily damaged.
Dr. Hurst, is there a way to open up your slides so that you don't see 2 sets of slides, just the one that you're presenting? Right now, there's 2 sets of slides showing up.
That's weird. I have no idea. I'm only seeing one. Well, let's see. Is it still 2 or now 1?
No, still 2.
That's very weird.
Okay. I don't know. I'm sorry.
That's okay. I've never run into this problem before. Let's just close a bunch of things and make sure that we got everything closed.
It's like it's showing your next slide in addition to your current slide.
All right, well, maybe we got the wrong. Let's make sure we do this. How about that?
No,
Still no?
still showing 2 slides.
I guess you're gonna have to put up with 2 slides because I don't know the, oh, great, now it won't advance. Are you still seeing 2?
Yeah, still seeing 2.
All right, sorry. Well, I guess we're gonna go with 2 because I can't tell what's wrong. This disease increases with age and is more common in males than females. Associated diseases such as epilepsy, alcoholism, and diabetes. Those groups of patients have more Dupuytren's than the normal population for reasons we don't completely understand. The initial structures we see in Dupuytren's disease are the nodules. These little lumps are under the skin. They can look like a callus, but they're not. And they are sometimes painful on presentation. The pain usually goes away, and sometimes occasionally even the nodule will go away, or the nodule can progress to become a cord. Ectopic fibromatoses that are associated with Dupuytren disease are plantar fibromatosis, Peyronie's disease, and knuckle pads as seen here. And in the foot, you see plantar fibromatosis. These lesions can be painful when they get big and it's hard to walk on them. Excising them is a problem because you wreck the septi and wreck the sole and sometimes end up with more pain. Occasionally, Dupuytren's presents as nodules at the wrist crease with no other findings. Here we see the first cord. The cord is not a tendon. It is under the skin, superficial to the flexor tendon, pulls the finger into flexion, usually 4th and 5th fingers most involved. Can involve the thumb, index, and the web, but less so than the ulnar digits. Dr. Houston noted the severity of Dupuytren's and recurrence was worse in those individuals who had a positive family history, who started with the disease at a young age, and who had other plantar or ectopic fibromatoses. He felt this group had what is now known as the Dupuytren's diathesis. They indeed are a subset of the normal population and are difficult to deal with. Remember, when dealing with Dupuytren's, a little contracture that causes no problem doesn't necessarily need an intervention. You should look for the symptoms, such as difficulty washing the face, holding your beer, etc. Indications for surgery include a positive tabletop test when you cannot place your fingers and your palm in the same flat surface and there's a gap. Contracture-wise, I usually recommended treatment when the NP joint was 20 to 30 degrees flexed and the PIP joint had a 20-degree contracture that was known to be worsening. A slight isolated PIP contracture that doesn't worsen may not need intervention. Here's a classic central cord and the excised Dupuytren's material. McFarlane in an old study showed that very small group actually got perfect results, and some part of the group, as much of a quarter, actually got worse. So surgery works, but it does have its limitations. There are gazillions of incisions that have been described for this. The hole you make in the skin doesn't guarantee what happens when you get the fascia out. And as long as you keep the skin from contracting and dying, the incision type isn't really too critical. The common ones used today are 2 versions of the zigzagplasty or Brunner incisions, a longitudinal incision which is turned into a Brunner by Z-plasty, or transverse incisions which were championed by McCash. Here's an example of a Brunner incision exposing the central cord and the Skoog ligaments, allowing good exposure to remove the cord while protecting the neurovascular structures. Again, you see here distally by the MP joints. The cord is easily separated from the other cords, and under the neurovascular bundles remain under Skoog's ligament, whereas proximally the cords coalesce and are a little more difficult to dissect at the level of the superficial arch. Here we see it being removed, again, in a central cord case. When you're designing incisions, I like to release the cord proximally before completing the design distally, because in really bad contractures, what you thought was a nice zigzag incision may turn rather straight when you straighten the finger after releasing the MP contracture in the palm. Some people try to preserve the transverse ligaments. I felt that releasing them and exposing the neurovascular bundles so I can follow the neurovascular bundles distally and protect them was useful. But that's what you're seeing here is the transverse ligaments under the clamp or over the clamp. Again, emphasizing the spiral cord. What spirals is the neurovascular bundle, not the cord. Brings the neurovascular bundle proximal, central, and superficially. This is a highly tested concept, and it is important when doing surgery. This superficial location of the neurovascular bundle is usually just about at the level of the first transverse finger crease. Here you see a cartoon with the neurovascular bundle seen there radially. Here's the spiral nerve ulnarly. Here's where the cord would be located, and there's the flexor tendon. Cords come in combinations. Here you see a fifth finger central cord in combination with a natatory cord going over the ring finger, produces a so-called Y cord combination, which can be treated either surgically or with needle aponeurotomy or Xiaflex. PIP contractures do occur. Isolated PIP contractures aren't too common, about 15%. Most of them come in combination with MP joint contracture related to central cord, which crosses both joints. Keep in mind when dealing with PIP contractures that the joint can be bent because it's arthritic, because the central slip is attenuated, the lateral bands are subluxed, the collaterals and volar plate are contracted, or even a tight flexor tendon sheath. PIP joints are extremely difficult to fully correct and even more difficult to keep fully corrected. When dealing with the fifth finger, keep in mind that there's actually two sensory nerves there of importance, the dorsal ulnar sensory nerve and the ulnar neurovascular bundle. The ulnar neurovascular bundle will become spiraled around the so-called abductor digiti minimi cord. And when dissecting this, you have to keep in mind both the spiraling of the neurovascular bundle and the presence of the dorsal nerve. Here you see the Grayson's ligaments of the fifth finger being dissected to expose the neurovascular bundle before going after the abductor digiti minimi cord. In this photo, you see the neurovascular bundle, the abductor digiti minimi cord, and the dorsal nerve. On the right-hand side, we see an example of a lateral cord, which is contracting the DIP joint. Usually the neurovascular bundle stays central to these lateral cords, as you see here in the photo. When you finish dissecting the fascia out, always let down the tourniquet, check the viability of the flaps, and check for bleeding. We do not want a hematoma. On the other hand, be very cautious with your bipolar cautery because the digital arteries are tiny and it's easy to cause disruption of the blood supply if you're too aggressive with your cautery. This is the open palm McCash technique. He was from Ireland. He used this transverse incisions to remove the cords and left the wounds open and claimed in 4 to 6 weeks, everybody healed up fine. The reason for his transverse incisions left open was to avoid skin grafts in older people where he wanted them to move right away and not get contractures. It does work. It's difficult to operate under the transverse flap, as you see there under the blue circle, and that's where the spiral cords occur. So it can be a more complex dissection that you have to be very cautious with, but it does work. It does allow immediate motion And they do heal up, but they usually take a bit longer than advertised. The radial side of the hand is less involved, but you will see commissural cords as seen here and radial cords. The X-ray shows a wire taped to the cords and how the cords relate to the underlying skeleton. And the view with the green dots shows where to place your Xiaflex if you're going to treat this with that type of injection. Here's a surgical case. The commissural cord is demonstrated, radial cord is demonstrated. Understand that the nerve to the radial side of the index finger is at risk here. The ulnar and radial nerve to the thumb is at risk, and they're all three are quite superficial. So cautious dissection, trying to identify the neurovascular structures before you aggressively remove the cord material. And often the web will have to be Z-plastied in order to prevent a contracture of the web from the surgical incision. Skin grafts are helpful. This one was being used for a thumb. You can see an old graft was used for previous surgery on the fourth and fifth fingers. They help deter recurrence. They don't stop it completely, but they can be a useful addition to your armamentarium when dealing with these by surgical intervention. Here's an example of a knuckle pad. This is sort of an example of what not to do. Knuckle pads that don't hurt and aren't too large are best left alone. They are completely adherent to the extensor tendon. There's no easy plane between the tendon and the nodule. And if you're not careful, you will excise the extensor tendon and cause a boutonniere deformity. So excision only if they're very painful or very large or both. This can be treated by closed fasciotomy. This was done around the time of World War II. Most people gave this up because of neurovascular injury. This has been replaced by doing needle aponeurotomies, where a small needle is placed through the skin into the cord numerous times until the cord is disrupted. People who are well trained in this have successful results. The recurrence is high. When all else fails, some salvage procedures are fusing of the PIP joint, a prosthesis of the PIP joint, and an amputation. In about 40 years of hand surgery, I did one amputation, no prostheses, and maybe a half dozen arthrodeses. The arthrodesis does work to get the finger out of the way and doesn't allow recurrent contracture of that joint. Complications include hematoma, infection, skin loss, nerve injury, vascular damage, and complex regional pain syndrome. And outcomes are variable. Collagenase came in after our articles in 2010. Here you see a cartoon of an injection of a central cord and manipulation.
Dr. Hurst is going to break the cord. There you go.
It does work. Recurrence is clearly a problem. When doing this, you identify the cord carefully. You palpate. You find the place where the cord is bowstrung away from the flexor tendons. That's where you place the injection of about 0.58 milligrams of the drug. It can be spread out along the cord. You can use 2 doses at a time now. So if you use a little extra collagenase that was in the bottle, that's okay. And this helps just weaken the bonds in the collagen and allows the manipulation that you saw done a day or two later after the injection. When injecting, the needle must be placed in the center of the cord, stabilize the barrel before pushing the plunger. You want the material in the cord, not in the subcutaneous tissue, and not in the flexor tendon. Manipulation, I tried to do it in 4 steps, really. Hyperextend the MP joint with the PIP flexed, hyperextend the PIP joint with the MP flexed, extend both joints, and then with the joints all extended, push on the cord and see what else I could pop with my palpating thumb or finger. Results showed in our cases, we had 50% with nodules that just got observation, 46% got collagenase, 5 still had surgery. Surgeries that I did included nodule excision, nodule with trigger release, fasciectomy of the palm and digits, fasciectomy and split thickness skin graft, occasionally fasciectomy with carpal tunnel syndrome, and occasionally using digit widget with various other modalities. Carpal tunnel and fasciectomy for a time were thought to be a no-no, but subsequent work has shown that you can do these two procedures without ruining the results of either one. 80% involved multiple digits. Recurrence after collagenase in our experience was about 10%. Recurrence post-surgery was 15%. The bottom line is you can't cure this. Here's an example of a central cord. The natatory cord combining with the central cord to make the Y cord, two natatory cords with the central cord making a so-called crowfoot cord, and the web cords, and then you'll find various complex combinations. Here's an example of a central cord, nice picture of it, palpation, figure in your brain, where exactly is the cord, where's the flexor tendon, identify the target, localize where you're going to put your collagenase.
All right, make it fast, sir.
And here's the result 2 weeks later. Splinting is used. This is historically something we always did. There's not very many studies about this. Probably splinting of MP contractures is not very necessary. PIP contractures probably benefit. And again, occasionally I use the digit widget in conjunction with either surgery or collagenase. For MP contractures treated with collagenase, we got 44%, 44 degrees improvement, 92% got straight. PIPs do worse, regardless of the treatment option you choose. Skin tears occur in about 15% with collagenase, but heal quickly. They're not really a problem. Other side effects of collagenase include itching, ecchymosis, no severe allergic reaction, no nerve injuries. Tendon injuries do occur. Fortunately, they're very rare. It has now been shown that you can safely give collagenase when people on Coumadin. However, the ecchymosis you see there on the left is extremely scary to you and the patient. However, 3 weeks later, it does resolve. Recurrence, no matter what you choose, Xiaflex or surgery or needle, that's the problem that's not resolved. Some of the rules of Dupuytren's disease to keep in mind are it can't be cured. It's not a fatal disease. Remember, if there's really no symptoms and minimal functional problems, it may be appropriate to just observe. Recurrence happens, it's not predictable. Patients generally like to avoid surgery, but sometimes that's the best alternative. Remember that the patient who can't make a fist is more unhappy than those who can't straighten their fingers. Before needle and before Xiaflex, aggressive surgery sometimes resulted in people who had straight fingers but no capacity to grip. Also remember the rusty hinge theory. Stiff PIP joints that cannot flex because of trouble with the joint are not going to be flexing just because you remove the Dupuytren's cord. You have to undertake these patients with the idea that you're going to be at their side for a long time. It's a lifelong disease, and it's common to have to help the patient on more than one occasion. Additional information is available in multiple publications and books. You can see a good chapter in it about it in our hand surgery resource app, Hand Surgery Source, and on the Hand Surgery Source portion of our website. Also, myself and our PhD team are writing a book on Dupuytren's disease and the science of Dupuytren's disease, which will be available next year. Thank you for your attention. I'm sorry you saw two versions of this thing side by side. I couldn't figure out how to fix it. Dr. Weber, are we still there?
Yes, thank you, Dr. Hurst.
Yes, so next will be Lauren, Dr. Lauren Grossman, discussing tenosynovitis. And Dr. Hurst, sorry to put you on the spot, but someone asked whether your lecture could be recorded. And if you can provide that to us, we'll add it to our list of pre-recorded slides.
I will do that. Just for information. Again, there's lots of information on Hand Surgery Resource. The Hand Society's series of 50 lectures. My lecture is one of those 50, so you can see it on the hand surgery site already. And I'll try to get it to you to put up on the New York site.
Thank you so much. Okay, so Dr. Hurst, you need to unshare your screen so that Dr. Grossman can share hers.
Did I get it, Dr. Weber?
I think so.
Okay.
Yes. Now Dr. Grossman's logging on. Perfect. Take it away, Lauren. And unmute yourself.
Hi, I'm going to be speaking to you about tenosynovitis of the upper extremity. Because it's a review course, I'm going to go through some questions that pertain to these tenosynovitis in order for the testing purposes. Okay. So I'll be going over trigger digits, Dequervain's tenosynovitis, intersection syndrome, FCR tendinopathy, ECU tendinopathy, and EPL tendinopathies. Starting off with trigger digits, it's a disproportion between the volume of the flexor sheath and its contents. We can see here on the bottom right, a phalanx and the fibroosseous tunnel of the A1 pulley. So which fibroosseous digital pulley is involved typically in the pathophysiology of a trigger finger? The A1 pulley. So the most common digits involved are the thumb, ring, and long fingers. Usually it's a nodular tendon enlargement at the A1 pulley, but there are other etiologies that can occur, such as rheumatoid tenosynovitis, causing inflammation around the tendons, triggering partial tendon injuries, which can present as a trigger finger, a partial cut. While the patient can flex and extend certain joints, the finger may trigger, and the history of a laceration should make you think of this. MP joint and PIP joint deformities. So here on the right, we see the pulley system. The most proximal is the A1 pulley, and then on the left, we see a dissection of the same. So what is the length of the A1 pulley? It seems pretty asinine, but they ask you this question, 7 to 10 millimeters. Into what structure does the A1 pulley insert? And that would be the MP joint volar plate. So treatment for trigger fingers, first you want to consider what stage the trigger finger is at. If you have a patient with a locked finger and has very difficulty extending it, probably considering injections may not necessarily be fruitful. Comorbidities, patients who have diabetes have a higher prevalence of trigger fingers compared to the general population. And then also knowing about inflammatory conditions such as RA as to what might help this patient. So studies have shown that therapy, splinting, NSAIDs really have not been helpful. Some therapists really swear by these MP joint splinting, haven't really seen many results with this that are overly helpful. Steroid injections have shown relief of symptoms for at least about 57% or so, but at a year, there are some that do recur. It did not seem to decrease the rate of surgery in diabetic patients. And most important of this is that an intra-sheath injection is really not much better than an extra sheath injection. The steroids tend to work similarly. So trigger finger releases, some pearls that are important to really keep in your head is make sure that you have the correct diagnosis going in to do a trigger finger release when a patient has a different problem. even though it presents similarly, will not obviously help the problem. So a lot of times patients will come in saying, my finger's locking, it's clicking on me, can't straighten it out. It looks as though you have a trigger finger, but a lot of times extensor tendon dysfunctions tend to present similarly, where you have a injury to the sagittal band on the radial aspect, and the tendon subluxes into the ulnar gutter over the MP joint, and it looks very similar to a trigger finger. Other flexor anomalies, joint synovitis, instability, and other sites of triggering. Here is a diagram or tendon showing sagittal band injury. Again, radial sagittal band injury can cause subluxation of the tendon into the ulnar gutter. Here we see on the right side, we see some nodules at the area of flexor tendons, which is causing those tendons to trigger, but this is a reason, a different site of triggering. So again, if you were to see this patient and see the finger triggers, you just want to make sure that there is no other evidence or abnormalities on your exam before moving forward with a standard trigger finger release. So there are different ways to perform releases. Some people do percutaneous releases, and you can do this using a needle. The main concerns with the trigger finger release are the complications, or the percutaneous are the complications, which are incomplete releases, and then superficial tendon and digital nerve injuries. Many people do it and are quite successful with this. Performing an open release, you want to make sure that you minimize your soft tissue planes and you protect your neurovascular bundles. The palmar neurosis also can cause a pulley, and that is a site of triggering, so you want to make sure that you release that as well. And if needed, you can also resect an ulnar slip of the FTS tendon. In performing a trigger thumb release, you want to make sure that you're protecting the radial digital nerve, both nerves, but the radial digital nerve crosses over in that area, so you want to make sure you see, you protect, and you retract. And then you also want to make sure you're releasing the A1 pulley and you are preserving the oblique pulley, A1 pulley and the oblique pulley, very important to maintain. Decurvain's tenosynovitis is also a very common problem. Tends to be known as the new mom's disease, but many other patients get it. It is a stenosing tenosynovitis at the first dorsal extensor compartment. You have the EPB and the APL in the first compartment. The APL has 2 or more slips sometimes and can be one of the issues. And the EPB tends to be a more common site of compression most of the time because it ends up being in a separate subcompartment. The sheath becomes stenotic or narrowed and causes pain and inflammation. So typically, how many EPB tendon slips would you expect to find at surgical exploration during a Decurvain's release? Again, as we went over, the APL is the one that tends to have 2 or more slips. The EPB only has 1. So here we see a picture of the first dorsal extensor compartment, and that's the area of the release. So pertinent anatomy for Decurvain's is, again, the APL is more palmar and radial to the EPB. It has 1 or more slips, and then there are accessory insertions. And the EPB typically has 1 slip, but 30% has its own subcompartment. But in Decurvain's, 70% of patients end up having a separate subcompartment. Here is a picture of the release, and the release is on the dorsal aspect of the first compartment. And here is a picture showing a subsheath for the EPB tendon. So it's important to have an appropriate history. It tends to really help make your diagnosis. You check your point of maximal tenderness, which is at the first compartment, doing a Finkelstein's test. Here we have an Eichhoff's test, which most people are calling the Finkelstein's test, where the thumb is held in the palm. The examiner radially deviates the wrist. The Finkelstein's test is holding on the thumb and then radially deviating the wrist, both causing similar areas of pain. The Finkelstein test tends to be a little bit gentler, not as painful. Brunelli test is also radial abducting the thumb. A lot of patients might say have difficulty doing this, and performing this test is also quite helpful. Differential diagnosis includes intersection syndrome, which tends to be more proximal and dorsal to the first dorsal extensor compartments. Other differential diagnoses are cervical radiculopathy, radial nerve injury, and here we can see a nice picture that the radial nerve basically directly overlies the first dorsal extensor compartment. Important anatomy question: the superficial branch of the radial nerve emerges at what interval? ECRL, ECRB. Here we see a brachioradialis on top and the ECRL on the bottom, and there's the branch of the nerve that comes in between. Important to make sure that you protect it. This is a little bit more proximal, but again, it can be an area of compression. Morton-Burke syndrome, again, it's compression of the nerve causing pain going distal to the hands. Other diagnoses, you've got basal joint arthritis, STT arthritis, radiocarpal arthritis, all can present similarly as it's on the radial aspect of the wrist. There are scaphoid fractures, scaphoid non-unions, giant cell tumors of the radius. So treatment considerations are patient education, letting them know what's going on, why it's happening, and how they can perform activity modifications. Sometimes that works and sometimes not. There's home program and therapy, works for a minimal amount of people, but there are some patients who really want to try some therapy before doing anything else. And then there are therapeutic modalities. We have evidence that really bracing tends to not help many patients, helps 30% of patients. Steroid injections have been helpful, has helped about 62% of patients. There are some patients that only need one that can need a few, but you want to make sure you limit to 2 to 3 injections, as it can cause injury to the tendon if you perform more. And then there are risks of the injection. So the risks of the injection can be depigmentation, as we see on the right side of the screen. You see that the skin has changed colors. There's fat necrosis, which causes some flattening underneath the skin, tissue atrophy. Diabetics, it can increase blood glucose for 5 to 6 days after the injection, and then corticosteroid flare. Here is a picture of surgical decompression. Sometimes you may want to perform a tenosynovectomy as well. Once you open it up, sometimes there tends to be a significant amount of tenosynovitis around the tendons, and that's good. When performing the surgery, you want to minimize your risk to the superficial branch or the radial sensory nerve. As we saw, it went directly over the area. So you want to spread longitudinally, retract, and make sure that way before moving forward with your release. You want to perform a incision over the dorsal retinaculum, over the EPB, in order to provide a shelf for the tendons to minimize subluxation of the tendons. You also want to make sure there is not a subcompartment for the EPB tendon. If there is, you release the subcompartment as well, and sometimes remove the septum, and then you confirm the tendon stability. Here again, we see different branches of the radial sensory nerve directly over the first compartment. Next is intersection syndrome. They tend to happen more, it's more dorsal and more proximal. It happens with flexion and extension of the wrist. And a lot of times you may hear or feel crepitus. Again, the yellow circle is the first compartment, whereas blue is the second, and the second is where you would see intersection syndrome. You tend to see pain and swelling due to the entrapment second compartment. It used to be thought that it was from the crossing over of the first to the second compartment, but it's really just entrapment of the second compartments. Again, the location is where the first compartment crosses, but it's really secondary to the entrapment of the second compartment. It tends to be seen in rowers and weightlifters. Again, diagnosis, tenderness, palpation, again, making sure that that area is more proximal and dorsal to the first compartment, so it's not confused with the two. Tend to have pain with wrist extension and flexion, crepitus. You can perform, a lot of times splinting is helpful. If splinting doesn't work, steroid injections can help as well. And then finally, if those don't help, there's surgery, which you perform a longitudinal incision to release the second compartment and leaving the retinaculum open. Next, moving on to FCR tendinopathy. It's significantly more common than you might think. It's pretty underappreciated, and often it is a chronic problem, chronic diagnosis. Differential diagnoses tend to perform an anatomic, cause an anatomic challenge. So with the FCR anatomy, it's redirected at the volar wrist towards the insertion at the base of the second metacarpal, and it goes through the trapezial tunnel, as we see here on the right. Diagnosis is again subjective in history, pain on the volar radial aspect of the wrist, pain gripping, lifting things, clinical examination is helpful. And then a lot of times performing an injection can be diagnostic, and sometimes therapeutic, and imaging is helpful as well. So what radiographic finding is associated commonly with an FCR tendinopathy? So as we saw, it went through the area of the trapezium, and we see STT arthritis, where there are osteophytes that can increase your risk of FCR tendinopathy. Here we have imaging of X-ray. You see mild STT arthritis on the MRI here. You also see this STT arthritis, which is significantly more evident. On the MRI also here we see volar radial aspect. The arrow is pointing to the FCR, which has inflammation around the tendon, and differences in that tendon compared to the rest of the tendons. The non-surgical treatment, again, patient education, activity modification, splinting, sometimes therapy and rehab, and then maybe a steroid injection. I found that it has helped some patients. Sometimes it comes right back, but it also could be helpful in diagnosing the patient. Performing your release, you want to make sure that you protect the paracutaneous branch of the median nerve. We see here on the right side of the screen an image where the hook is holding the FCR radially. You have the superficial branch of the median nerve, and then you also see the median nerve as well. You perform a tenosyntectomy. You can release sometimes a subsheath and then the tunnel, which you see distally, that fibroosseous tunnel. You see it right over here. And then if it's a really severe case, it can also be performed. Next is ECU tendinopathy. ECU tendinopathy can be sometimes difficult to diagnose as an undecided wrist pain, which is a whole black box of some diagnoses. It's the sixth dorsal compartment, and it goes through a fibroosseous tunnel. And again, ulnar-sided wrist pain, TFCC problems, J problems, and so forth. In the diagnosis, you have localized tenderness on the ulnar aspect of the wrist, a lot of times at the base of the fifth metacarpal where it attaches. Sometimes it causes pain that goes more proximally by the head of the ulna and even more proximally. An ECU synergy test, which is testing the strain in that area that causes pain directly at the area of the ECU. Check for tendon stability. Sometimes the ECU sublux over the ECU, over the ulnar head, and then imaging is also helpful. So with the synergy test, okay, that video doesn't work, sorry. So imagine in your head, the examiner places the patient's table on the hand on the table. You flex the elbow at 90 degrees, so the hand is in the air. Your forearm is in full supination, and then the examiner will resist the thumb abduction with a counterforce on the long finger of the patient, which then produces pain at the ECU. Again, differential diagnosis, TFCC pathology, which they're intertwined, a lot of them both the time they come together, CRUJ pathology, LT, mid-carpal problems, and sometimes piezoterrestrial OA, which sometimes is a bit more volar. And here we see an MRI, you see inflammation again around the ECU tendon, and that is indicative. So non-surgical treatment, once again, I know I sound like a broken record. Patient education, activity modification, splinting, therapy sometimes helps. Sometimes injections are also helpful for patients. When performing surgery, you make an incision along the radial aspect of the compartment to minimize subluxation of the tendon. Afterwards, you perform a tendon debridement, a retinacular repair, and if we tendon stabilization, minimize subluxation or dislocation of the tendon ulnarly. And finally, we have EPL tendinitis. This tendon entrapment usually is rarely seen. The majority of the time, you see these patients after the EPL is already ruptured. Most of the time, it's associated with some sort of wrist trauma, such as a non-displaced radius fracture, sometimes an inflammatory arthropathy, which causes stenosis around the area of the tendon. These problems tend to lead to attritional rupture, but if prior to rupture, you're able to catch it, performing a release and subcutaneous transposition can be preventative to minimize that risk of rupture. Patients complain of pain over the area of the EPL. Most of the time as it crosses over on the wrist by the third compartment. Patients have pain with extension of the thumb off of the table, and they against resistance and have pain in the wrist with that tendinitis. MRIs will show sometimes, like all the others, inflammation around the tendons, signaling. If it ends up rupturing, then you need to perform a reconstruction versus any sort of repair. Then it would be IP-EPL tendon transfer. Again, checking for a rupture, we see here on the right, there's full extension of the thumb. On the left, you see the thumb is flexed and unable to extend. The best test really to check for the EPL rupture is actually having the patient place their hand flatly on the table and extending the thumb from the table. And that really gives you a diagnosis of a rupture. And again, ideally you catch that rupture or you catch it before the rupture if possible, based on patient symptoms. Thank you.
Okay, our next presenter is Dr. Gilbert discussing compression neuropathy. We are running about 10 minutes behind, but hopefully we'll make up for that. And again, questions, there are some questions from the audience, and we'll be covering those at the end of this session at 12:45, 12:50, whenever we finish. Thank you.
Can everybody see my screen?
Yes.
Okay. I'm going to go through compression neuropathy. It's a lot to go through. I'll try to go through this on time. Remember, this will be loaded up on the website. So we'll start with carpal tunnel syndrome, certainly the most common compression neuropathy that we see. And you certainly want to know the anatomy of the median nerve. And in addition, the anatomy of the carpal tunnel. Remember, and I'll somewhat gauge this towards some questions that can be asked on the OIT. The FPL is within the carpal tunnel and the FCR is not. And obviously the median nerve is, that's what results in carpal tunnel syndrome. You also want to know variations of the median nerve. In general, the palmar cutaneous branch of the median nerve originates 5 centimeters proximal to the wrist flexion crease. Usually this is not an issue when you're dealing with carpal tunnel release. It is, as was discussed by Dr. Grossman, as well as when we're approaching a distal radius fracture volarly. More pertinent to a carpal tunnel release is the recurrent motor branch, and there's some good, an excellent study by Lance, an anatomic study which showed the variability, and the majority of the recurrent motor branches come off radially and distally to the transverse carpal ligament. So when we release the transverse carpal ligament, we want to release it along its ulnar margin to prevent injury to the recurrent motor branch. So what causes carpal tunnel syndrome? Well, anything that causes an increase in carpal tunnel pressure can result in carpal tunnel syndrome. Most often it's idiopathic. In general, we see these in patients who are elderly, females more commonly than males. And certainly we know that there are certain medical conditions that predispose patients toward developing this. Most commonly is diabetes and hypothyroidism. So you do want to get a good history just so you know what is the etiology. Pregnancy can result in carpal tunnel syndrome as well because of the increased retained fluid resulting in tenosynovitis. You can also develop an acute carpal tunnel syndrome from either distal radius fracture or forearm compartment syndrome, tight dressings, et cetera. And these are medical emergencies. So how do you diagnose carpal tunnel syndrome? Well, there are many ways, but in my opinion, I think the majority of patients can be diagnosed based upon the history itself. Patients have complaints of numbness and tingling in their hand. Oftentimes they describe that they need to wring out their hand to bring circulation. They think it's a circulatory problem, but as we know, it's not. It's a neurologic condition. And anything that keeps the wrist flexed prolonged times or repetitively, such as sleeping at night when we keep our wrist flexed, or driving, reading a book, et cetera, increases the pressure of the median nerve within the carpal tunnel, and this can result in symptoms. So you want to do a good sensory exam. We all know the distribution of the median nerve. And the important thing is really just touching is not, so touching the finger is not a very good way of really diagnosing carpal tunnel syndrome, at least in its early stages. By the time a patient loses sensitivity, this is probably advanced carpal tunnel syndrome. Innervation density tests are relatively insensitive. Threshold tests such as Sums-Weinstein and vibrometry are much more sensitive. We in general do not do these in our office. These are more often done by our CHT colleagues or in studies, but just keep this in mind. You want to examine the hand. You want to look for thenar atrophy as well as weakness. Again, these are late stages of carpal tunnel syndrome. And then there are provocative tests. There's the Tinel sign, where you tap along the median nerve, just at or proximal to the carpal tunnel. The Phelan's test depicted here, where you have the patient flex the wrist for anywhere from 30 to 60 seconds, and this increases the pressure within the carpal tunnel, resulting in symptoms. The Durkin's compression test, which as you see is a much more accurate test, where you basically compress the median nerve at or proximal to the wrist flexion crease, resulting in symptoms. And my sort of go-to test is a wrist flexion carpal compression test, which is the most specific test, and it's essentially a combination of the Phelan's and Durkin's tests. And this is a pretty good test. And these exams you can do within a minute or two and have a pretty good idea of what's going on. A little bit on electromyography. I think to some extent it is falling out of favor, although it still is the gold standard. It's operator dependent. It's important to know that negative tests do not necessarily mean that disease is absent. Anywhere up to 20% of patients who have carpal tunnel syndrome may have normal or equivocal EMGs, and it has not been shown to correlate with outcome to treatment. And in fact, EMGs generally don't normalize even after successful decompression. Ultrasound is beginning to somewhat supplant EMGs. There are many advantages. It's much less expensive. It's quick. It's non-invasive. Patients are comfortable, and EMG is not a comfortable test. You get immediate results. And you can also diagnose other concomitant etiologies for the carpal tunnel syndrome if present, such as tenosynovitis and ganglia. A good diagnostic parameter to remember is if you have a median nerve cross-sectional area greater than or equal to 10 millimeters squared at the wrist flexion crease or at the level of the pisiform, this is diagnostic of carpal tunnel syndrome. Certainly have been some studies recently showing a higher sensitivity and specificity than even EMGs. It is somewhat operator dependent. There are many hand surgeons who are comfortable performing this test in their office, and you do not need to send the patient for EMGs, but certainly EMGs are still something that are a test that is commonly ordered. So how do we treat carpal tunnel syndrome? Well, certainly you want to know the underlying diagnosis, and if necessary, have the patient be treated for the underlying diagnosis. If the symptoms are mild, you can treat them initially with splinting. So patient has mostly symptoms at night. In most patients, this does not lead to long-term relief of their symptoms. Steroid injections do help the symptoms in the majority of patients, but it really depends upon the extent of the carpal tunnel syndrome, and only about 1 in 5 patients gets long-term relief. But particularly, I like a steroid injection, 1, for patients with mild symptoms, or 2, to judge their response to surgery. So if you have a patient who has, let's say, a cervical radiculopathy as well as carpal tunnel syndrome, and you're not certain which way to go in terms of treatment, their response to a cortisone injection is relatively predictive of their response to surgery. And certainly you'll have a happier patient who is going to undergo carpal tunnel release as opposed to go for cervical fusion and not have relief of their symptoms, knowing that they should have just had their carpal tunnel released. And medications, they've been studied exhaustively. We really have no proven benefit over placebo, particularly vitamin B6, which there used to be some literature supporting this. I still see many patients who get this prescribed, particularly by neurologists, and there's really no use. If it is, it's a placebo effect. So surgery options are open release. You can do a mini open release or an endoscopic release. One thing to remember is that both techniques are essentially equivalent at 3 months. It's an earlier return to work and an earlier recovery for endoscopic, but really it's just based upon your training and what you're comfortable with. I would say in the 90s, there was some literature showing that there were a higher complication rate with the endoscopic technique, particularly iatrogenic nerve or vessel injury. And most studies over the past 20 years have shown that this is not really true. A couple of things to remember: routine antibiotics are not indicated for open carpal tunnel release, as well as most soft tissue procedures. Splinting is not really necessary, and OT in most patients is not necessary. So I'll throw in a couple questions that came out from recent OITs. Which physical examination finding among patients with carpal tunnel syndrome has the highest specificity? Well, the wrist flexion carpal compression test, as we discussed earlier. What is the most common pattern of branching of the thenar motor branch of the median nerve at the level of transverse carpal ligament? Again, the anatomic study by Lance. It's extraligamentous, most commonly comes distally and radially to the distal aspect of the transverse carpal ligament. An otherwise healthy 42-year-old woman is scheduled for carpal tunnel release. The physician should adhere to routine sterility protocols. And do we need antibiotics? No, without local or systemic antibiotics. Okay, on to cubital tunnel syndrome, which is the second most common upper extremity compression neuropathy. These patients present with numbness and tingling along the ulnar nerve distribution, the ulnar 1.5 digits, as depicted in this lower left-hand picture. In more advanced cases, patients can have intrinsic atrophy. And remember, the ulnar nerve provides the majority of the intrinsic strength and muscles within the hand. So much more so than carpal tunnel syndrome, the median nerve only innervates the thenar muscle. So these patients in late stages will have much worse symptoms in terms of hand function. Late stages, you can see clawing, and obviously you don't want the patient to get to this point. Examination, a lot of these exams are very similar to what we do on the median nerve. You can tap over the nerve, Tinel sign, you can compress the nerve, and you can also have the patient flex the elbow, and this stretches the nerve, decreasing the vascularity of the nerve, and this results in symptoms of numbness and tingling along the ulnar nerve distribution. You should certainly examine the stability of the ulnar nerve. This is particularly important if a patient is undergoing surgery, because if they have an unstable nerve, then you will likely need to transpose the nerve. Also keep in mind, though, that there is certainly a subset of patients who have a subluxable ulnar nerve without symptoms of cubital tunnel syndrome. So just because they have a subluxable ulnar nerve does not necessarily mean that they will have symptoms of cubital tunnel syndrome. I'll quickly go through this, but basically these are tests looking for intrinsic weakness. So sometimes patients have difficulty crossing their fingers, Frohman sign. This is always fodder for testing questions. It's secondary to weakness of the adductor pollicis. You can ask the patient to hold something like a piece of paper between their thumb and the radial side of their hand at the web space, and you'll try to pull it out. And because of the weakness of the ulnar innervated adductor, they'll flex at the IP joint, compensating with the FPL. You can have Wartenberg sign secondary to unopposed EDM pull, as you see on the right here. This should not be confused with Wartenberg syndrome, as was discussed previously. And the papal sign, which is clawing, and obviously this is a late sign that you do not want to see. So I think more important than with carpal tunnel syndrome, you want to keep a differential diagnosis in the back of your mind, because cubital tunnel syndrome CAT1 can be mimicked by cervical radiculopathy or thoracic outlet syndrome, which commonly affects the lower cords. So you want to get a good history and examination. Diagnosis: EMGs are not always positive and notoriously are negative, particularly in patients who have early stage symptoms. And just because they have a negative EMG does not mean that they do not have disease that requires treatment. I do not always get EMGs on my patients unless, I need to for some medical legal reason. Oftentimes, unfortunately, insurance companies do require EMGs, or if I'm worried about concomitant cervical radiculopathy or another site of compression. Ultrasound is emerging as a diagnostic tool, although the parameters are not as clearly defined as in carpal tunnel syndrome. Routine X-rays and MRI are not indicated unless there's a history of an injury or trauma. These are the 5 sites of compression from proximal to distal. They certainly like to ask about the arcadia of Struthers. The arcadia of Struthers is a fibroaponeurotic band of tissue that goes from the medial intermuscular septum to the medial head of the triceps, and usually about 8 centimeters proximal to the medial epicondyle. Osborne's ligament is another name for the roof of the roof of cubital tunnel. I think a good thing to just remember is you want to release the nerve approximately 8 centimeters proximal and distal to the medial epicondyle, and you want to keep all these structures in the back of your mind and take care of them. So conservative treatment, you can try splinting. It's poorly tolerated. I tell patients that certainly not all patients require surgery for cubital tunnel syndrome, but there's not a lot to do between doing nothing and surgery. Steroid injections, at least in my hands, has not been very successful, and it's not really been shown to be too successful in the literature. There are a lot of procedures that are described. I would say over the past 10 years, most hand or upper extremity surgeons have gone to an in situ release. What's important is most studies have demonstrated no superiority of one procedure over the others, and 90% of patients do well no matter what procedures you do if their symptoms are mild. And obviously, the advantage to an in situ release is that it's a minimally invasive procedure. It's a quicker recovery and fewer complications. So who are not candidates for in situ release? Well, if you have a subluxable ulnar nerve, then you need to transpose the nerve, because if you leave it there, it's still going to be irritated. And if you notice that a patient has a subluxable ulnar nerve before surgery, then you know you're going to transpose them. But after you release the nerve, you need to check whether or not it's subluxing as well, because if it does after release, then you need to transpose it. Patients who have RA or OA, where something medially may compress the nerve if you're leaving in the cubital tunnel, will require transposition of valgus deformity, because you'll still have the tenting and pull on the ulnar nerve should be transposed, as well as revision procedure, as well as overhead throwing athletes. All of these, you should probably do some type of in situ release. When you're performing this procedure, just remember to protect the medial antebrachial cutaneous nerve branches, which are in the area, particularly if you're doing some type of transposition. A patient with a neuroma of the medial antebrachial cutaneous nerve branch is a very unhappy patient. Here's just some pictures that I took from the NYSSH, and this is just showing a submuscular transposition. I do not think there are many surgeons at this point in time that will perform this as a primary procedure. As you see, it's a relatively involved procedure, but it certainly is probably the procedure of choice if you're doing a revision. So a couple questions. What is the reason for thumb IP joint flexion with lateral pinch in ulnar nerve palsy? We went over this. It's secondary to unbalanced flexion torque of the FPL at the IP joint, which is taking over the weakened adductor pollicis. The presence of an anconeus epitrochlearis muscle is associated with slowing of the conduction velocity of which nerve? ulnar. It actually may not be associated with slowing of the conduction velocity, but they're telling you that this is cubital tunnel syndrome. And here's a depiction of ankynesia petrocliaris. If you're releasing the ulnar nerve and you see a muscle there, that's what it is, and you need to release it. That's it. And finally, when comparing an in situ ulnar nerve decompression versus anterior transposition and circle treatment of cubital tunnel syndrome, anterior transposition affords no difference. Doesn't matter what you do. Okay. Guillen's canal compression. These patients also present with numbness and tingling along the ulnar nerve distribution, but remember, the dorsal ulnar sensory nerve branches out proximal to Guillen's canal, so you will have normal sensation in this region as opposed to a patient who has cubital tunnel syndrome. These patients can get motor atrophy and weakness and clawing as well. And in late stages, the clawing will be worse actually than in cubital tunnel syndrome because your FDPA of the ring and little fingers, which are innervated more proximally by the ulnar nerve, are still intact. So with that intact flexion of these, the unimposed flexion by the intact FDP, your clawing will be more severe oftentimes than in cubital tunnel syndrome. Also have to remember that not uncommonly, Guillen's canal compression can be secondary to space occupying lesions. So you want to keep this in the back of your mind. They're listed here. And if necessary, get a diagnostic test. This you can read on your own. The Guillen's canal compression is described in 3 zones from proximal to distal. The important thing to remember is zone 1 is proximal to the bifurcation. So you'll have both sensory and motor findings as opposed to zone 2, where it's just the motor branch, and zone 3 is a sensory disturbance just from the sensory branch. Diagnosis. In terms of EMGs, I will get EMGs fairly routinely if I think a patient has Guillen's canal compression, because I want to make certain that they do not have a more proximal compression as well, where you need to release the ulnar nerve of the cubital tunnel or some other etiology such as cervical radiculopathy. If you're concerned about a space occupying lesion, you should image them with either an MRI or an MR, as well as vascular lesions such as a ulnar artery aneurysm. You may want to do some type of diagnostic vascular study. Treatment, again, you can try splinting, activity modification. In terms of surgery, if you have a primarily compression of Guillen's canal, you want to release Guillen's canal. Studies have been shown that carpal tunnel release will indirectly release Guillen's canal because the floor of Guillen's canal is made up from the roof of the transverse carpal ligament. But I think if you are certain that they have Guillen's canal compression as well, it behooves you to release Guillen's canal as well. And obviously, take care of any space occupying lesion. Here's just a picture of a patient who had a ulnar artery thrombosis that was compressing the ulnar nerve. And this can be treated. Obviously, you want to try to diagnose this before, do a good Allen's test. And this can either be diagnosed, treated with ligation, depending upon the Allen test, although I think most people will reconstruct this with a vein graft. A couple quick questions. Which of the following is an anatomical component of the floor of the distal ulnar tunnel or Guillen's canal? As I said before, transverse carpal ligament. We'll quickly finish up with radial tunnel syndrome. So radial tunnel syndrome is a pain syndrome. It is not a neurologic syndrome. You do not have neurologic findings. Patients have pain right over this area, and it can be confused with lateral epicondylitis, which can coexist. Oftentimes secondary to repetitive tasks, swelling, inflammatory conditions, sometimes from patients with rheumatoid or other inflammatory conditions compressing this area. Remember, PIN syndrome is different than radial tunnel syndrome. Radial tunnel syndrome is purely a pain syndrome. PIN is actually a syndrome where you can compression of the posterior interosseous nerve and you actually get motor findings. You can get a PIN palsy, and this is usually secondary to some type of space occupying lesions. Lipomas have a predilection. I always like to ask sometimes a patient with rheumatoid arthritis where they have radiocapitellar synovitis. Diagnosis is generally a diagnosis based upon examination. Patients have pain in this area. Just remember, this is a relatively painful area, so always examine the contralateral form. Don't confuse this with cubital tunnel syndrome. pain can be increased with resistant supination. Sometimes patients describe the pain as gnawing, almost like a toothache in their forearm. EMGs are not helpful. Do not get these. They're normal. Again, this is a pain syndrome, secondary compression of a nerve, but not a compression neuropathy. Conservative treatment can try activity modification, splinting, cortisone injections. I find that the majority of patients with this condition can be treated non-operatively. These are the 5 sites of compression from proximal to distal. The arcata froche, which is a fibroaponeurotic leading edge of the supinator. And these are certainly sites that are oftentimes questioned on examination. Here's a picture. Left is proximal, right is distal. Right over here is the posterior interosseous nerve. This is the supinator. This is superficial head of the supinator, and this is the arcata froche, the leading fibroaponeurotic edge of the supinator. When questioned, proximal dorsal forearm pain with supination against resistance is a finding used to support the diagnosis of radial tunnel syndrome. Thank you. I will stop sharing, and our last but not least lecture is given by Dr. Steve Lee, probably the most complicated lecture on brachial plexus. Steve is really one of the world's experts on this condition, so we are lucky to have him lecture.
Thanks, Rich. Can everybody hear me okay?
Yes.
All right, thanks so much. Yeah, thanks for hanging in there. I know it's a lot of info in this relatively short time, but I'm going to try to be, get to the salient points of a very complex topic in 20 minutes. So this is our brachial plexus and reconstruction. Let's see, I'm not advancing it here for some reason here. Okay, there we go. All right, so brachial plexus injuries are devastating, potential source of major disability. They have multiple possible causes. A study back in 2014 showed that mostly male, I think we know this, young, a lot of motorcycles. Half of them are complete, meaning the entire extremity, upper extremity is a flail limb. 30% are the upper and 21% upper plus. We'll get to that. And very uncommonly where it's just the hand. A lot of associated injuries, you can see. Trying to take the plexus, which is kind of like a black box from medical school, hopefully not in 1943, to the current OR. Most common mechanism is traction. Very commonly, the patient will fall off a motorcycle, the head hits the ground, the shoulder hits the ground, and there's a massive stretch to the area. Birth palsy, the head comes out of the canal, shoulder doesn't come out, and there's a stretch, but it's lower energy. Therefore, because of this energy difference in the adult, it's more preganglionic. We'll get to that in a minute. But there's root avulsions, meaning the roots are pulled out of the spinal cord, meaning that there is never any possible chance of recovery on its own. Pediatric, more commonly, the roots are intact and there's more chance for recovery. Also, a big difference between adults and peds is that it's difficult to reanimate the hand in an adult, not possible. For peds, you can get the hand back because it's a shorter distance of regeneration, and babies and kids, people under 20 regenerate much faster. Other mechanisms other than traction would be sharp laceration, gunshot wounds. Other things could be masses, tumors, iatrogenic. I see this actually, unfortunately, quite often when there's shoulder surgery and so forth. Regarding anatomy, I talked about that before, but super important, and this is actually a very common kind of question on examinations, is to determine if it's super or infraganglionic. What that means is that if it's supraganglion, it's closer to the brain from the dorsal root ganglion. And if it's the supraganglionic, that is synonymous basically with ripping out of the spinal cord or the ruptures, where the infraganglionic is after the ganglion and it's not a rupture. So very important. And, these terms are kind of strange, like avulsion versus rupture. You can't really tell just by that name. But once again, if it's avulsed, then ripped out of spinal cord, you don't have a live nerve root anymore, and you have to bring in accents from somewhere else, and that's via nerve transfer. If you just have a stretch here, there can be spontaneous recovery. And then if you have the rupture where it's discontinuous, but the roots are into the spinal cord still, you could potentially graft that. Regarding evaluation, it's the injuries can be very complex and hard to understand, but if you can really just kind of whittle it down to a couple key points. If somebody calls up and says they had plexus injury, the main things, just with a few questions, you can figure out a lot. One is, when did it happen? Because if it happened a long time ago, you can't do nerve surgery, you have to do something else. And when I say a long time ago, I mean more than a year. If it is somebody who can move the shoulder or cannot move the shoulder or bend the elbow, but the hand works, you can open and close the hand, that is going to be a 5-6 or 5-6-7. Because of 5-6, the upper 5-6, 5-6-7 region, that innervates the more proximal muscles, or the 8-1 or more hand type muscles. If the person cannot move anything, shoulder or hand or elbow, then that'd be a complete. And then very rare if the hand doesn't work, but they can bend the elbow and move the shoulder. That is a very rare type. Very important when you examine a patient that you see their entire torso and their extremities. So you can you have to look at the back, you have to look at the face, we'll go over why that is. But if they have a supraganglionic, they're going to have a flail extremity. But you will see, look for wing scapula, weak rhomboids, and Horner's, because those are root level nerves that come out. If it's just infraganglionic and they don't have the other signs, that's just a flail arm, then that's infra. So here's a condition. If I had you in a room, I'd be quizzing people, but this is Horner syndrome, where there's ptosis, or the drooping eyelid, constriction of the pupil, and anhidrosis. That's because of paralysis of the sympathetic nerves that come out of C8-T1 roots. And those are signs of avulsion. So if you see a Horner's, that's a bad sign. That means C8-T1 are avulsed. So you want to look at their eyes and see. It's poor prognosis for any spontaneous recovery because of avulsion, as I just said. Myelograms can be done. Now, we're kind of in a transition point where high quality MRIs may supplant CT mylos. In some places, CT mylos are done. Some places, MRIs are done. We still do CT mylos, as does the Mayo Clinic. But what you're looking for are these traumatic meningocele, which are signs of root avulsion, because the roots pull out of the spinal cord, the dura rips, and then over time that dura heals. And then if you do a myelogram, say a month later, more dye will fill up into this healed dura that's bigger than usual, and it'll look like that. And those are signs of root avulsion. You can also see on these CT myelograms actually the lack of rootlets. So if you look at that left side of the picture, you see these little black lines coming out of the spinal cord. Those are the rootlets. And then if you see on the right side of the screen where that red circle is, you don't see those tiny little rootlets coming out. Those are signs of avulsion. MRI is good for non-traumatic plexopathies like tumors. EMGs are done 4 to 6 weeks post-injury, and then we do serial EMGs for following for recovery in that same time frame, 4 to 6 weeks, up to 3 months. What we're looking for are signs of super or infra ganglionic denervation, as well as the pattern and what's denervated. If you have paravertebral muscles denervated, that's a sign of supraganglionic injury, negative or poor prognostic sign, as we discussed. Regarding nerve conduction studies, is this strange paradox in that if the person cannot feel their extremity, but they have a waveform in the sensory distribution, that's a bad thing, because if you see that bottom left picture, if you have root avulsion, the dorsal root ganglion is still attached to the distal extremity, and you will get a positive waveform when you do a nerve conduction study, but the person can't feel. So it's this paradox. This is actually pretty commonly asked in exams. They'll have somebody, they'll give this scenario, and what they're trying to get at many times in exam questions is if it's super or infraganglionic. They'll show Horner's or something, and they'll show things like this nerve conduction study, and that's leading to the path. They may say, can you graft that root or something? And the answer is you can't do that. Or is this a good sign or bad sign? Things like that. Regarding surgery, the surgery fits into several categories. One clump is nerve surgery, which is nerve grafting and transfer. Just doing a neurolysis isn't really, that's not enough for true major plexus injuries. Generally, you're doing nerve grafting and nerve transfer. or secondary reconstruction, which are done either if the patient presents too late for nerve surgery or they had nerve surgery and it failed. Then you can do other things, potentially tendon transfers, free muscle transfers, and fusions. For a standard traction injury, we'll do, as I said, serial examinations, physical examinations, also serial EMGs up to 3 months. And then the surgery window is generally 3 to 6 months. The exception to that is if you knew that somebody had 5 root level avulsions or the majority root level avulsions right off the bat, there's no reason to wait because there's no spontaneous recovery possible. The reason we wait for 3 months is that some of these could be neuropraxic, and different from what you learn in med school and even maybe residency, neuropraxia is not 6 weeks to recover, it's 3 months to recover. So if somebody doesn't have good recovery, like actually moving the extremity, not just twitching of muscles, but actually anti-gravity of muscles by 3 months, then they'll not have good recovery. So, and then if you do surgery after 6 months, then the outcomes get worse. So that's why there's that golden window between 3 and 6 months. If the motor end plates, so the motor end plates and the distal nerve, they fade away after a while. And if you cannot reinnervate those motor end plates by 12 to 18 months, then you cannot do nerve surgery. So, and you have to, each case is different because it depends on where the level of the injury is, how big the person is. So as you may recall, the nerves regenerate about 1 millimeter a day. And if you just measure it out, you'll see that, you know, certain scenarios, it just won't, those motor arm plates won't be around anymore. So you don't do nerve surgery. What are you trying to do? You're trying to assess what they, what the major deficits are, what nerves that may receive the input, what donor nerves you have. Kind of like tendon transfers, you know, what are you lacking? What do you have to give? So nerve surgery is the same way. 2 most common upper extremity deficits that require treatment would be elbow flexion and shoulder abduction, external rotation, and stability, it should say in there. When somebody has a plexus injury and they can't move their shoulder or their elbow, a couple bad things happen, in addition to just not being able to use the extremity. But some other things happen that are actually even worse, is that the shoulder or the extremity just hangs and it hurts, and it actually doesn't feel connected to the body, and it actually will affect their ambulation. Because just imagine if you have this dead weight hanging on your torso that you can't move and it's not connected to your body, it actually affects everything. So just getting shoulder stability and even a little bit of motion, not even great motion that looks good on a video, but just some stability of the shoulder and some motion is very helpful. Having the elbow bend, you know, if the elbow is just hanging there, you have to wear a sling for the rest of your life. So those are really 2 things that are key things we try to get back. Other things are to stabilize scapula, elbow extension, because if you ever get more than 90 degrees of abduction to shoulder, that your hand will just flop down and hit you in the head. Also, if you can extend the elbow, you can push down on things and it can be a helping extremity. Later things that you can't always get would be distal things, anything distal to the elbow, such as these. Those are not usual to get in a 5 level. And we'll talk about that a little later. How do you approach them surgically? You know, we kind of break it up into above the clavicle or the supraclavicular approach, or below the clavicle, the infraclavicular approach. We do have some good videos on, it's called the HSSE Academy. You want to write that down and just look up anatomy videos and plexus. We have some stuff on there that's kind of shows us in some detail with dissections and cases. To know this plexus anatomy, you know, we're not talking just like med school anatomy anymore. If you're going to be in this area at all for any reason, or you decide to do these operations, or even if you have to go up here for something else, you know, if you're a trauma surgeon or something, you might be here a spine surgeon, you know, got to know some of this stuff. So basically the plexus comes out between the anterior middle scalenes, as does the subclavian artery. The vein is anterior to the anterior scalene, and on top of the anterior scalene is the phrenic nerve as well. So a lot of stuff around there that you have to be careful of. Going back to this again, is that above the clavicle, you can see the roots. Difficult to see the lower roots because of great vessels there. So generally you're seeing 5, 6, and then maybe 7. Upper trunk you can see. And then if you remember that mnemonic of the roots, trunks, divisions that you see from this picture are below the clavicle. We generally do not do clavicular osteotomy, so it's very hard to see divisions. And then below the clavicle, you'll see cords, and then you'll see the you know, the terminal branches, and that's that famous M sign that you can see. Below the clavicle, you'll do a deltoid pec approach, and then down the arm and the medial arm. There's a soft spot that's under the biceps that you can palpate. Potentially to see this area, you have to take down the pec major. If you want to see all this area in great detail, you have to take the pec major off the humerus and then repair it at the end. Release the pec minor as well to move this out of the way, so then you can see the plexus underneath it. For people who are budding shoulder surgeons, this plexus is very close to the shoulder joint. It's unfortunately injured. Of course, I get a skewed view because I do a lot of nerve surgery, so I see these injuries after shoulder surgeries. But just be aware that it's very close to all this action here. Be careful with retraction. Be careful with arthroscopic techniques, particularly like Hagel repairs. I would not recommend doing that arthroscopically. We've seen hydrostatic injury to nerves, stitches through nerves, and so forth. So it's around here, shoulder. Find this famous M. You have on the upper part the muscocutaneous nerve. Then you have the middle one that is the easiest to see in the arm is the median nerve. It's most kind of prominent. And then you have the ulnar nerve, and that's that famous M. How do you treat it? Nerve grafting, we talked about. You can do long nerve grafts. Those are 5-6 nerve roots shown there in the left panel there, right above that blue background. That's above the clavicle approach. And then nerve grafts look like this. They're generally sural nerves that are cabled and then pass under the clavicle, which you see that Penrose is under the clavicle, would pass it. I do a different passing technique. That's getting too much in the weeds, but we're doing a case like this in a couple of weeks, actually, 5 level. And you pass that, and those nerve grafts can be quite long. They can be 10 to 15 centimeters, and it does work. We published this Journal of Hand Surgery, 2014, and we compare this to nerve transfers, and long grafts do work. What you have to do is have good nerves on both ends, and this is just standard. Very important principle of nerve reconstruction is you have to have good proximal and distal nerve ends, and you have to have it so there's enough time for regeneration before the motor end plates dissipate. If you have avulsion, we talked about that. The roots are not attached to the spinal cord, so you have to bypass that with the nerve transfers. Not by now an old paper, but I see it's very frequently referenced still. Nerve transfers have really revolutionized nerve surgery, and it's just really taking a healthy donor nerve and bring it to a denervated nerve stump, kind of like tendon transfers, but with nerve. First generation, the oldest ones are taking things that are outside the plexus, bring it to the plexus, the spinal accessory nerve, cranial nerve 11 brought to the suprascapular nerve, which innervates super and infraspinatus muscles. It's a very classic one, still frequently done. It's a key transfer for shoulder function. Getting to the rotator cuff, you can stabilize the shoulder and initiate elevation. Usually done as a dual transfer part from triceps axillary nerve. Intercostal nerve is also an extraplexal transfer. Strange when you think about it, you're taking rib, like breathing nerves between the ribs, and you're bringing to the arm. A very challenging operation to do, challenging to retrain a patient to use it as well. I have some images later showing this, but common recipients would be muscutaneous nerve, axillary nerve, long thoracic nerve, and also free function muscle transfers, the DOI procedure, DOI from Japan. Intercostal nerves do work, but not all the time. It's again very challenging surgery and recovery. About 70% will give anti-gravity function, though, published in 2001. It's a case of mine. To give you reference, the head is up top, feet down below. The extremity is to the right of your screen, and those are the ribs on the left side of your screen. Tiny little nerves, those are the intercostal nerves. The bigger nerves, the bottom, that bigger one is the muscutaneous nerve, and up top on the blue background, the bigger, the one that's the recipient is the axillary nerve. The 3-4 intercostal nerves have been glued together, and so that's why they look bigger. This is that same patient who had that operation. And you can see this function that's returned, not to her hand. She's a 5-level injury. In addition to those intercostals and those nerves that you just saw there, she also had one to the long thoracic nerve, one intercostal. She had a spinal accessory to suprascapular nerve, and also 2 sensory intercostal nerves to the lateral cord contribution to the median nerve to give sensory to the hand. Second generation intraplexal transfer. So this is within the plexus, not coming from extraplexal nerves. The classic one is this one for exams, and this is the transfer that we have. This is kind of the gold standard to compare everything else to, but the original was the ulnar nerve fascicle. So you open an intact ulnar nerve. So this is a patient who has, this is the classic thing to ask is when do you do this transfer? The classic one is somebody who has a C5-6 plexus injury. So in that person, they can't move the shoulder or the elbow, they can't bend the elbow, but they can open and close the hand. So the ulnar nerve is intact. You open up the ulnar nerve, you take out a fascicular tube, and you hook it to the nerve to the biceps. It's the terminal branch of the muscocutaneous nerve. In this 1994 paper, Journal Hand Surgery, 2/3 had anti-gravity. And then later, McKinnon and Oberlin came up separately with this dual transfer, also called the double fascicular transfer, the DFT. What you're taking is the original one, but you're also taking median nerve fascicles to the brachialis. You're going both to the biceps and the brachialis. You double up. And McKinnon published 2005. They all worked. This is a really good transfer. I've done many of these. They work. I mean, knock on wood. I just did one not too long ago, and but they've worked every time so far. That's what it looks like. You know, to give you a reference, the head is to the upper right in this picture. The hand is going to be to the left, and those are the connections. Fascicles are taken out of the median and ulnar nerve separately, going to the actual nerves that are going right to the biceps and right to the brachialis. My partner Scott Wolf published 2011 JBGS meta-analysis looking at this for this double fascicular transfer, 83%. With M4, 96 was M3 or greater. So, I mean, very high chance that it's going to work. Regarding how, what kind of axon counts, you take tiny nerves and bring it to the recipients. We found that for optimal, you need at least 70% donor to recipient ratio. This is a case, another one of mine, where the patient had a small accessory to suprascapular nerve, C5 root grafted to the axillary nerve, and a double fascicular transfer. 1 year after the DFT, you can see the scar there. You can see the muscle in her biceps there. You can also see in this one, once again, that see the muscle, the deltoid, and the going back here, it's the right extremity. So let's look at this right extremity again. And what you're seeing here, look at the bulk in her biceps, look at a bulk in her deltoid. You can see the scar in her leg. So it's a big scar, but for somebody who can't move their extremity, it's huge to get that back. 3 years post-op, you can see her elevation, not normal. She's going to maybe, 9,500 degrees, but she can externally rotate, very important to get that, so you can get your hand away from your body to do stuff. You can see her bending her elbow as well. It's a different case. This is the classic triple transfer, a C5-6 who had spinal accessory to suprascapular nerve. For the axillary, this is a triceps axillary, and then a DFT. And you can see, it's obviously his left upper extremity. You can see it working. This triceps axillary, what this looks like is, and you can do it from the back or you can do it from the axillary approach. But what you're doing is you're taking a branch, and we can be here for another hour talking about all the types of ways that the different ways we do these. This is the originally described way. Take the long head branch, the triceps, and swing it up to the anterior component of the axillary nerve. I can refer you to a paper that we published talking about all the branches of the triceps that was published a few years ago in Journal Hand Surgery. This is actually after it's connected. The original paper is from Somsak Alisha Waywang. You might hear it called the Somsak procedure. That's his first name. In Thailand, they actually refer themselves to their first name because their last names are too long. But in the literature, you'll see this last name, and that is Somsak, same person. Anyway, had good results with this. Third generation, to wrap it up, would be, this is the classic one you got to know. This is also frequently asked about. This is for somebody who has an ulnar motor problem. You take the distal AIN that goes to the peroneal quadratus, and you take that nerve component and you bring it to the motor component of the ulnar nerve, not the entire ulnar nerve. McKinnon published that she had decent results. Actually, later retracted, it's not this strong, but what it does usually is it helps you have not a claw hand. A claw hand is a very problematic thing. You can really have trouble opening your hand and using it. And if you can at least get anti-claw, it is very helpful. Secondary reconstructions, once again, I mentioned if you have a late injury, can't do nerve surgery, or if you've already done nerve surgery and it didn't work, you can do things like this. You can take free muscle transfers, take a gracilis muscle from the leg or the thigh, and you can bring it up to help with elbow flexion and even wrist finger extension. This is written up by Doi, D-O-I. In the literature, you can look those up. Looks like this, you go to the leg, you harvest, and bring it up as a free flap. Other things you could do would be potential trapezius transfer. You take that trapezius, you move it down to the humerus. That's the SAHA procedure, S-A-H-A. It's a challenging operation. You have to put the person up in a splint, a brace that keeps their arm up, elevated, and externally rotated. It's very challenging post-op kind of protocol. Latissimus transfer, a whole bunch of tendon transfers, shoulder. You could read Bassam Al-Hassan's work. Shoulder arthrodesis, not that commonly done, but that's another potential thing you can do. So what's new? Better outcomes reporting. There's a lot of publications. We have several publications about outcomes. We have a score called the impact score that looks at functional outcomes for plexus problems that we published a couple of years ago. Also on the horizon would be if the hand doesn't come back, you actually do an amputation and give an advanced prosthesis, myoelectric prosthesis with articulating digits. In summary, plexus injuries are devastating. Reconstruction best under 6 months, and secondary reconstruction can be employed at later stages. Thank you very much.
All right. So I'm going to share my screen as soon as Dr. Lee comes off.
Okay, I think I'm off.
Yes, you are. All right. Let's see. So now starts our question and answer period. There were a couple of questions throughout the afternoon session, which Dr. Gilbert and I have answered. So if there is any other questions, please submit them now. Otherwise, we'll do a quick wrap up and end the day. Going once, going twice, going 3 times, no questions. Just a reminder again, Dr. Kim is going to add his secondary reconstruction lecture. He's going to record that, and then we'll be submitting that or uploading it to our website. I actually misspoke earlier. Dr. Grossman spoke about sclerosing tenosynovitis, so I will add my lecture on infectious tenosynovitis. I'll record that and I'll upload that to our website as well. And Dr. Hurst will send us a link to his presentation so that we can see that in the larger view, since we were having some technical difficulties. All right, so once again, I want to thank everybody for, number one, spending the morning with us. Thank you to our sponsors. It's very hard to get sponsors to, donate, especially when it's a virtual meeting and they don't have any person-to-person contact. So we do want to thank them for sponsoring us, in addition to sponsoring us for the resident night back in May. I want to thank all the faculty for their recorded lectures, for spending the morning with us this morning to give live lectures, for answering questions, and for giving up a Saturday to be here with us. And lastly, I want to thank Dr. Richard Gilbert for his time, for his dedication. There's a lot of work that goes into planning this meeting behind the scenes, and he made it look very, very easy. It's a labor of love from all of us. And just because we love teaching doesn't mean or doesn't minimize the amount of time and energy that it goes into creating all these presentations. So thank you to everyone, and see you in December for our next meeting. Thank you.
Okay, thanks everybody. Thanks Renata. Thanks Rich.
Thanks, Renata. Thanks, everybody. Appreciate it.
Okay, have a great rest of the weekend. See ya.
Bye-bye.
Thank you.